friends, we are now going to be having a discussion about the most important points with respect to the topic of hematology. Now, the first important image that you find in this particular section is going to be a demonstration between the techniques which are going to be given the name of bone marrow aspiration, and we do a procedure which is given the name of bone marrow biopsy. Now, so many times in the exams, they have asked you about the ways by which you are going to be identifying the different types of needle for performing the procedure in each of them. So as and when we are talking about something like bone marrow aspiration, we are going to be using two types of needles. Either we can be using the Sahla's needle or we can be using the Klima's needle. Now, whenever you say the word Klima and Sahla's, you are going to be having a phonetical sound of A. Klima, A, Sala, A. And that would help you always remember the fact that these are the needles which are quite commonly used for performing bone marrow aspiration. The moment we are talking about the differentiation between the Sahla's and the Klima's needle, Sahla's needle is going to be having the presence of a side screw, whereas the Klima's needle is not going to be having the same. The procedure by which we perform the bone marrow aspiration is going to be that you are going to be taking the piece of the tissue in the patient depending upon the age group. So when we are talking about a normal adult, this is going to be the commonest site from where you're going to be performing the procedure is going to be the posterior superior iliac spine. Please be familiar with the fact in case when an individual happens to be excessively obese, in case the individual happens to be excessively overweight, you would be taking the tissue from the anterior superior iliac spine. Watch out for a question in the exam which talks about in the carrying out a procedure in case of an infant, wherein the preferred site then is going to be answered by you in the exam as tibia. Now, whenever we are going to be talking about the bone marrow aspiration, this is to be differentiated from bone marrow biopsy. For the bone marrow biopsy, you are going to be using a thicker needle, and this kind of a needle, we have plenty of them, but the one which is being depicted over here is given the name of Jamshedi's needle. Two facts that I would like you to be familiar with over here. When we are talking about the bone marrow biopsy, you are actually going to be getting the tissue and you are going to be decalcifying it before you observe it. In terms of bone marrow aspiration, when you get the tissue, you are going to be air drying it on the slide. You are going to be fixing it. So what they can possibly ask you is the name of the fixative. In case of aspiration, the fixative that we are commonly using is 95% methanol. The disadvantage that we have with bone marrow aspiration is that in case of certain conditions about which you are already familiar, say for example myelofibrosis, you might not be able to aspirate anything. So that is what is given the name of a dry tap. Those are exactly the conditions where you would prefer to go in for something like bone marrow biopsy in order to confirm your diagnosis. Be familiar with the fact when you're talking about the bone marrow examination, this is typically done in order to make a diagnosis of infiltrative disorders, granulomatous disorders, for that matter neoplastic disorders as well. Be familiar with the fact one of the common areas of mistake which has to be avoided is that even if the patient is going to be having a platelet count which is going to be less. So in the NEET PG exam, they gave you a platelet count less than 40,000. Remember, that is not going to be a contraindication for carrying out these procedures. The reason is fairly obvious. When the patient is going to be having thrombocytopenia, you have to distinguish whether the patient is going to be having a megakaryocytic thrombocytopenia or he is having presence of a megakaryocytic thrombocytopenia, the two important subtypes which I have explained to you in the main video section of platelets. So how would you distinguish between the megakaryocytic and the amegakaryocytic causes of thrombocytopenia? That can be achieved only and only when you perform a procedure like the bone marrow examination. So the sites are important, the different types of needles are important, the indications are important, and you need to be familiar with the fundamental difference between them. Say for example, in myelofibrosis or dry trap patients, what you're going to be performing is a bone marrow biopsy. So that was an example of an image which came in the exam recently, and this is obviously going to be an example of the bone marrow biopsy needle. And we need to be familiar with the fact that thrombocytopenia is not going to be a contraindication, rather it is helpful in distinguishing between the causes of thrombocytopenia. Additionally, as I said, the other causes like neoplastic, the infiltrative and the granulomatous disorders. Talking about the cell which is appearing on your screen, this cell is going to be having the presence of a reticulin meshwork. So logically understanding the fact that this is a cell which is going to be given the name of a reticulocyte. Now as and when we are talking about the reticulocyte is going to be the example of the first cell in the development of the RBC, which is going to be a non-nucleated cell. When we are talking about this kind of a cell, the cell is going to be associated with an important property. You are going to be using the supravital stains because this cell can be identified only in a living state. One of the best stains which can be useful for identification of a reticulocyte happens to be the new methylene blue. The moment we are talking about reticulocyte, importance of knowing about reticulocyte happens to be the fact that within 24 to 48 hours, it is going to get converted into a mature red blood cell. The reticulocyte count is going to be a rough indicator of the fact whether the bone marrow is going to be hypoactive or it is going to be hyperactive. So there are certain types of formulas that we must always remember with respect to something like reticulocyte. Questions in the exam can be numerical based questions which can be asking about how to calculate a reticulocyte percentage. Reticulocyte percentage obviously can be calculated number of reticulocytes divided by the total number of RBCs into 100. So that is going to be the simple percentage. The reverse can be given for the calculation of an absolute reticulocyte count, wherein they talk about the presence of reticulocyte percentage, and you know the RBC count, and you can calculate the absolute reticulocyte count. Questions in the exam that should never be missed are going to be with respect to something like corrected reticulocyte count. When you talk about corrected reticulocyte count, the formula happens to be the percentage of reticulocytes, and that is to be multiplied by the hematocrit of the patient divided by the reference or the normal hematocrit, which is likely to be around 45 in case of an adult male. So the advantage of calculation of the corrected reticulocyte count is that this is going to eliminate the chances of a erroneously high or an erroneously low reticulocyte count. Why corrected reticulocyte count is also going to be important is because this can help you calculate what is given the name of RPI or reticulocyte production index. This reticulocyte production index is going to be calculated simply by calculation of CRC, that is corrected reticulocyte count, and this has to be divided with what is given the name of maturation factor. Now, if you do not remember the formula for CRC, obviously then you have to remember the complete formula over here: percentage of reticulocyte multiplied by individuals or the patient's hematocrit divided by the reference hematocrit. So this is going to be the formula for CRC. So CRC divided by maturation factor. Now, what is very important to be keeping in mind is that maturation factor values are dependent upon the values which are going to be dependent upon the hematocrit. So if the hematocrit is more than 36, the maturation factor is going to be 1. If the hematocrit is between 26 to 35, the maturation factor is going to be 1.5. If the hematocrit is going to be between 16 to 25, the maturation factor is going to be 2. And if the hematocrit is less than 15, the maturation factor is to be remembered as 2.5. So till now in the exams, they have asked you questions pertaining to the absolute reticulocyte count. They have asked you questions with regards to corrected reticulocyte count, but obviously in a subsequent INI-CET exam, you can expect a question on the reticulocyte production index. As I said earlier, if the RPI is going to be having a value less than 2, that is a cause of hypoproliferative anemia. And if there is going to be a value which is going to be more than 3, as described in the textbook of medicine, that is going to be an example of a hyperproliferative anemia. So that's an important thing, important parameters that you need to remember so far as reticulocytes is concerned. We should not be forgetting the fact that when we are talking about the development of the RBC, the first stage in the development of the RBC where you can see for the presence of appearance of hemoglobin, especially with the help of electron microscopy, is to be remembered as the proerythroblast or the pronormoblast. Watch out for a question which talks about the presence or detection of hemoglobin in case of the RBC with the routine staining, that is to be picked up as the intermediate normoblast. So this is what we need to remember so far as the reticulocyte is concerned. Now, looking at the example of a normal smear, the normal smear is important for us to be familiar with because fact number 1, this would give you an idea with regards to a gross problem with respect to the RBCs, white blood cells and the platelets. Remember the fact when you're going to be making a smear, it is the feathered end. Suppose this is where you place the sample, you're going to be making a smear like this. It is the feathered end where you're going to be actually examining the slide for the presence of the cells. The RBCs, as you can make out clearly, are going to be the cells which are going to predominate all the other cells. These RBCs are going to be having the presence of a central 1/3 pale area. In case of a patient who is going to be having more than 1/3 central pale area, that is going to be suggestive of the presence of a microcytic hypochromic cells. You can also see for the presence of the white blood cells, so you can obviously make out the presence of something like a neutrophil over here, and you can find the presence of a cell which is having a reniform nucleus, quite likely to be suggestive of something like a monocyte. We need to be familiar with the presence of a dot-like appearance over here, which is going to be associated with something like platelets. Please be familiar with the fact that this kind of a smear is going to be important because, as I said, this might as well give you a hint regarding the patient suffering from either the type of anemia, for example, the microcytic hyperchromic anemia, or can be talking about a patient who is going to be suffering from a megaloblastic anemia. Similarly, in case of certain types of platelet disorders, you may find very scanty platelets, or you can find platelets which are going to be very small, or they can be example of platelets which are going to be very big. So appearance and identification of a normal smear is going to be a good important hint for you to remember as to what is going to be the expected pathology that you are going to be finding in the subsequent detailed examination. Of course, with respect to the RBCs, we talk about certain parameters which are going to be the mean cell hemoglobin, the mean cell volume, the mean cell hemoglobin concentration, and there is going to be a variation in the individual size of the RBCs which is given the name of anisocytosis. I want you to remember the fact that how exactly are we going to be talking about anisocytosis? This is going to be with the help of red cell distribution width. So for cracking a previous exam question, you just need to be familiar. The normal red cell distribution width is going to be between 11.5 to 14.5. So that takes care of the appearance of a normal smear. Now having a look at the important cause of development of anemia so far as a developing country is concerned, we need to be familiar with the commonest cause, that is going to be iron deficiency anemia. With regards to normal iron metabolism, lot of questions are asked in the exam on a regular basis, so make sure that you have a very good pictographic memory of this kind of the normal iron metabolism. Iron is going to be getting absorbed from the GI tract, particularly it is going to be getting absorbed from the duodenum, and the form in which iron is going to be getting absorbed is going to be the ferrous form. Now we need to be familiar with the fact that as and when the ferrous form of the iron is going to get absorbed, this is going to be facilitated because of the transporter present over here, which is given the name of DMT1. The DMT1 stands for the divalent metal transporter 1. This is an example of a non-specific transporter because as the name gives you a hint, it is responsible for facilitating the absorption of all types of divalent metal cations. Once the iron is going to be present inside the gastric epithelial cells, it is then going to be coming out from the basal surface because of the presence of a transporter over here, which is going to be given the name of ferroportin. So ferro is iron, it is being ported in, iron is being transported inside the body because of presence of ferroportin. Remember the fact, the form in which iron is going to get absorbed is going to be the ferrous form, but the form in which iron is likely to be transported and further stored is going to be the ferric form, which means that ferrous form of the iron has to be converted into the ferric form, and this oxidation process is going to be done because of another important basal membrane protein which is given the name of hephaestine. A similar function can be carried out by a protein that is given the name of ceruloplasmin. Now you heard about ceruloplasmin earlier in biochemistry because of its role in copper metabolism, but the point over here is that both hephaestine as well as the copper metabolism protein, which is going to be ceruloplasmin, are going to be important for the oxidation of iron from the ferrous to the ferric state. Why that becomes important for us to understand is that now when the ferric form of the iron is present, this is going to get attached with a molecule present in the blood, which is given the name of transferrin. So iron is transported in the blood, transfer of iron in the blood because of a molecule given the name of transferrin. One molecule of transferrin theoretically can bind to 6 molecules of iron, but in reality the transferrin is only 1/3 or 33% saturated. So out of 6 iron attachment sites, there is actual attachment of iron molecules to only 2 sites. This transferrin is going to take iron into the storage sites, and one of the common sites for storage of iron happens to be the bone marrow and the liver. In the bone marrow and the liver, you are having the presence of transferrin receptor, because of which the transferrin which is attached with iron is going to get internalized. The iron which is available is now going to get converted into the storage form of iron, which is going to be given the name of ferritin. This ferritin is likely to be toxic, and therefore this has to be converted into a relatively inert material, which is going to be hemosiderin. So far as hemosiderin is concerned, since you have already hopefully watched the cell injury topic as well as you have gone through the RR section, wherein we talked about the presence of hemosiderin being detected in the bone marrow with the help of a special stain which is given the name of Prussian blue. Remember the name of the reaction as well, that is given the name of Pearl's reaction. So presence of hemosiderin is going to be an indicator of the amount of storage form of iron that is available in the body. So when we talk about absorption, keywords: duodenum, divalent metal transporter, ferrous form. When we are talking about the transport of iron coming inside the body, ferroportin, you need to remember the role of ceruloplasmin and hephaestine. Transport of iron, the keyword to be remembered over here is transferrin and 2 molecules of iron. And as and when we are talking about the storage form, we need to be familiar with the terms like ferritin and hemosiderin, not to forget that the chief sites for storage of iron are going to be the liver and the bone marrow. Why that becomes important for us to understand is also because of the fact that we can understand certain parameters as we made a mention of. So certain parameters that we made a mention of were like serum iron, the amount of iron that is actually present inside the blood, total iron binding capacity, the theoretical amount of iron which can bind with the transferrin molecule provided all the sites are saturated. We then talk about the serum ferritin, which is going to be the ferritin from the bone marrow which is going to get diffused into the blood, and therefore an easier and an alternative test for performance of the storage iron. So instead of doing a bone marrow ferritin study, it is easier for anybody to perform a serum ferritin. And then we obviously make a mention of the other important parameters that we have made detailed about in the main section videos. So this important table is going to be high stuff for your exams. Now repeatedly what they have asked in the exams is going to be the role of certain other additional proteins over here, one of which happens to be an example of an iron regulatory protein given the name of hepcidin. Hepcidin is an example of a hepatic protein, and this hepcidin actually is going to block, it is going to reduce the activity of ferroportin. If it reduces the activity of ferroportin, iron cannot be absorbed properly. Similarly, ferroportin molecules are also present on the surface of the bone marrow cells, and therefore, if there is going to be more amount of hepcidin, iron cannot be released from the bone marrow, iron cannot be entering from the gut. And therefore, this hepcidin is going to play a very critical role in the pathogenesis of a condition which is given the name of anemia of chronic disease. So all said and done, I want you to request few seconds of your precious time to look at this particular slide so as to crack all possible questions in the exam with regards to iron metabolism. Now talking about the important example of the anemia which is seen in our country, we need to be familiar with the concept of the iron deficiency anemia. As and when we are talking about the iron deficiency anemia, it is going to be characterized by the presence of this kind of a characteristic slide, which is going to be showing you presence of RBCs which are having pale central area. So the central areas in these RBCs, as you can possibly make out, exceed the 1/3 cutoff mark that we talked about earlier, which is present in a normal RBC, and therefore such RBCs are going to be associated with the term, we call them by the name of the microcytic hypochromic RBCs. So microcytic hypochromic RBCs. The point I would like you to understand over here is that presence of microcytic hypochromic RBCs is not the best way by which you make a diagnosis of iron deficiency anemia. Why? Because there are going to be other conditions as well which are going to be characterized by microcytic hypochromic RBCs, and we have talked about them in detail in the main videos. They are going to be preferably the 4 or 5 conditions you need to remember: sideroblastic anemia including lead poisoning, iron deficiency anemia which is the commonest one, thalassemia, and anemia of chronic disease. So examiners would love to ask you and probe you about more details with respect to a question given a slide of microcytic hypochromic anemia. One of the best ways by which you can make a diagnosis of iron deficiency anemia can be, you can carry out an invasive procedure, say for example the bone marrow examination, where you detect the presence of a low storage form of iron. Of course, if I have to talk about the blood test, all the parameters pertaining to RBCs, be it MCV, be it MCH, be it MCHC, all those parameters are likely to be reduced. The important thing that I would like to make a mention of over here is going to be the fact that in the bone marrow also, even the presence of the normoblasts are going to be smaller, so that is given the name of the micronormoblasts. However, what we need to remember over here is going to be the fact that as and when we are making a differentiation between the different conditions, as I just made a mention of something like Sita, I wanted to be familiar with the fact examiners would love to ask you a question pertaining to the differentiation between a condition given the name of iron deficiency anemia and thalassemia, and that is going to be done on the basis of a index which is going to be given the name of Mentzer index. We got a lot of questions in the recent exams, and therefore talking about Mentzer index is simply calculated. In the numerator you would be keeping the value of the mean cell volume. In the denominator you would be keeping the value of the RBC count. As and when, and if you calculate the Mentzer index, if the value is going to be less than 13, this is very much suggestive that the patient is going to be suffering from thalassemia. If the value of the Mentzer index is going to be more than 13, very much suggestive of the presence of iron deficiency anemia. So that has been a previous AIIMS exam question. A modification of this question was given in the recent INI-CET exam as well, wherein they wanted you to first calculate the Mentzer index given the picture of a microcytic hypochromic anemia and the RBC parameters, and then they wanted you to confirm the diagnosis. I mean, once you are aware that the patient is having, let us say, a value of Mentzer index less than 13, that is suggestive of thalassemia. Then they wanted you to confirm the diagnosis of thalassemia by performing either an HPLC of the hemoglobin, or for that matter a globin gene sequencing, or for that matter the other investigation like hemoglobin electrophoresis. And if the question would have been with respect to something like iron deficiency anemia, then obviously we would have confirmed the diagnosis by carrying out either the bone marrow examination, or we carry out the ratio that I talked about with you earlier. The serum ferritin is to log ferritin, the serum transferrin receptor is to the log ferritin ratio, which is typically going to be having a value less than 1.5. By the way, that particular ratio which I am making a mention of over here, the serum transferrin receptor over the log ferritin ratio, is also going to be helpful for distinguishing between iron deficiency anemia as well as anemia of chronic disease. So in context of iron deficiency anemia, the value is going to be, as we understand, it is going to be over here, this is going to be less than 1.5, over here the value is going to be more than 1.5. That is one of the ways by which you are going to be distinguished between this kind of a fact. Needless to say, some of the cells over here can be having the presence of bizarre shape as well. When you are having the presence of bizarre shaped cells, that is given the name of poikilocytosis. And of course, if you are going to be having the presence of pencil shaped cells, that can be other way of making a mention of something like poikilocytosis. So watch out for the fact, if you are talking about abnormal size, the term used is anisocytosis. anisocytosis. As you find over here, some RBCs are going to be having this size, some are smaller, some are yet smaller, some are yet more smaller. So variation in the size, that is anisocytosis. Variation in the shape is what is given the name of poikilocytosis. We made a mention of the fact that as and when we wish to treat a patient having iron deficiency anemia, obviously you have to treat the primary cause, be it malnutrition, be it gastric ulcer, be it a cancer, and obviously to take care of the reduced hemoglobin percentage, you have to give supplementation to this individual with the help of iron supplementation. Now that is pharmacology, whether you give the supplementation in the form of an oral administration or with the help of parenteral administration. So this is what we need to have an idea so far as a microcytic hypochromic anemia is concerned. Talking about an example of a condition in which the examiners would specifically make a mention of a microcytic hypochromic anemia, and in addition to that they would perhaps make a mention of the fact that the patient was having a history of either consumption of too much of an alcohol, or the exam question can talk about a patient who was having the development of lead poisoning, or a patient having an administration of a drug like isoniazid, or the patient is going to be having the presence of something like a myelodysplastic syndrome. Now you need to identify that iron in such situations can have a deposition around the perinuclear area, and this kind of an appearance of the developing cell is given the name of a sideroblast, the ring sideroblast. So ring sideroblasts are going to be seen in case of two conditions. One, the patients could be having the presence of sideroblastic anemia, or that can also be seen in a patient who is going to be suffering from myelodysplastic syndrome. Now, the histories are going to be very helpful in distinguishing these causes, and of course, there are going to be different etiological factors to them as well. So, far as sideroblastic anemia is concerned, that can be an example of a genetic condition. It can be X-linked recessive. And when we are talking about the acquired causes, we have alcohol, we have lead, we have isoniazid administration, which can all cause development of this kind of a condition. One of the characteristic features that we have with sideroblastic anemia obviously is what is appearing on your screen. The second thing that they ask you in the exam is going to be the questions pertaining to the iron profile. So whenever we are talking about a patient who is going to be having iron deficiency anemia, I can just have a quick recap for you. Patients are going to be having a decrease in the serum iron. They are going to be having a decrease in the percentage saturation of iron. They are going to be having the presence of, however, an increase in the total iron binding capacity. So iron deficiency anemia patients are going to be having an increase in the value of total iron binding capacity. But when we are talking about a patient who is going to be suffering from sideroblastic anemia, I want you to remember the fact that these patients are going to be having elevated values of serum ferritin. They would be having elevated values of percentage iron saturation. They would be having elevated values of serum iron. All those values are going to be increased. But when you're talking about something like total iron binding capacity, this value is going to be reduced. So in ascension, what I would like you to be familiar with over here is the ascens part is that sideroblastic anemia, the parameters or the profiles are going to be exactly opposite of what you would expect to have in a patient suffering from iron deficiency anemia. Management of sideroblastic anemia would depend upon the cause. If it is an example of a genetic condition, you can't do much. But obviously, if it is an example of an acquired cause, you can do the needful to help the patient out when he is going to be suffering from this condition. Talking about the next important example of an image which is going to be a hot favorite for the examiners, wherein they talk about the presence of a peripheral smear in which you find the presence of RBCs which are not going to be having the presence of even a very good central 1/3 pale area. So you have the presence of RBCs, but you cannot appreciate the central 1/3 pale area. On the other hand, what you have in these situations is that there is going to be presence of WBCs, and these WBCs are having presence of more than 5 segments of the nuclear lobes. So this is an example of a hypersegmented neutrophil. And as and when we make a mention of the hypersegmented neutrophil, a hypersegmented neutrophil is going to be associated with the diagnosis of the condition that can be made out over here can be something like a megaloblastic anemia. The moment we are talking about a megaloblastic anemia, that is going to be an example of a condition which can be seen in a patient who is either going to be having a B12 deficiency or the patient is going to be having a folic acid deficiency. We need to be familiar with the fact that in case of a patient having B12 deficiency, characteristically, it's more commonly going to be seen in people who are going to be absolute vegans, who are not having the consumption of any kind of an animal product. So far as the folic acid deficiency is concerned, that is something which is going to be relatively, I would say, less common because we are all in the habit of consuming the foliage or the green leafy vegetables. Folic acid transporter is what is going to be present so far as a chromosome 21q is concerned. We also need to be familiar with the fact that as and when the patient is going to be having this kind of a picture, you are going to be confirming your diagnosis with the help of the presence of something like serum B12 levels, or you can go in for something like RBC folate levels. One of the special causes of B12 deficiency can be an autoimmune cause, and when you talk about that autoimmune cause, we need to be familiar with the fact that the patients could be having the presence of something like the pernicious anemia. Additionally, patients who are going to be having B12 deficiency are also going to be having the presence of neurological manifestations. The neurological manifestations are going to be clearly evident on the basis of the presence of what is given the name of SACD. that is subacute combined degeneration of the spinal cord, which I explained you, ascending and descending tracts are affected. Patients would be having the presence of a peripheral neuropathy, history of paresthesia, tingling, all that would go in favor of a patient suffering from B12 deficiency. So megaloblastic anemia plus neurological symptoms would go in favor of B12 deficiency. If the question is associated with absence of any neurological manifestation, that would be associated with something like a folic acid deficiency. We also need to be familiar with the fact that sometimes when we are talking about the management of these situations, it is obviously first important thing is to confirm your diagnosis by doing the respective tests, and then you are going to administer the patient therapeutic supplementation. As we talk about that fact in the main videos and I was asked in the exam, you should never ever start folic acid alone. It is always best that you first confirm the diagnosis of folic acid deficiency, and if the patient is having an isolated folic acid deficiency, only then folic acid has to be started. It should never be given in the initial part when you have an undiagnosed case of megaloblastic anemia. Now, having said that, the image based questions exam can be talking about this kind of fact where you have the involvement of the dorsal column. As you can see over here, the pink area is suggestive of the fact that there is a demyelination over here. One of the recent questions exam was with respect to the patient who was having the presence of pernicious anemia, and one of the reasons why patients could be having pernicious anemia can be the fact that sometimes patients can be having a very uncommon presentation which can be in the form of development of hyperpigmentation of the knuckles. Hyperpigmentation of the knuckles. The reason why the patients having B12 deficiency are going to be having the presence of hyperpigmentation of the knuckles is what I explained you earlier as well, friends. B12 deficiency is going to be responsible for causing an increase in the activity of the tyrosinase enzyme. And this tyrosinase enzyme is going to be responsible for then causing transfer of more amount of melanin at the level of the limbs, particularly at the level of the knuckles. So patients are going to be having the presence of that kind of a hyperpigmentation. The good point about having this kind of a hyperpigmentation is as and when you administer B12 supplementation to this individual, the individual is going to get better. So presence of megaloblastic anemia plus neurological symptoms goes in favor of B12 deficiency. Presence of megaloblastic anemia along with that kind of a hyperpigmentation, even though it is rare, can also be giving you a hint that the patient is suffering from B12 deficiency. The next important example of a question is going to be showing you the presence of a peripheral smear, and what is very evident in this peripheral smear is RBCs do not have a central pallor. The moment we are talking about a question which is going to be having RBCs having absence of central pallor, what we are looking at over here is presence of spherocytes. Now, presence of spherical cells in the peripheral smear can be associated with multiple conditions. The commonest condition out of that happens to be a condition given the name of autoimmune hemolytic anemia. Of course, that can be seen in a patient suffering from hereditary spherocytosis, might as well be seen in a patient who's going to be suffering from a condition like G6PD deficiency. Now, the commonest reason for spherical RBCs is autoimmune hemolytic anemia, which is a condition in which there is formation of antibodies against the RBC antigens. Depending upon the nature of the antibodies, this can be an example of a warm or a cold subtype of autoimmune hemolytic anemia, which I'm just going to be talking about few minutes down the line. If we are talking about a genetic condition, one of the example of a condition which is going to be autosomal dominant. I repeat that, autosomal dominant condition, which is seen because of mainly a problem at the level of enchirin, is a condition that is given the name of hereditary spherocytosis. We need to be familiar with the fact that in this kind of a condition, patients are going to be having the presence of jaundice, patients would be having anemia, they would be having the presence of quite characteristically splenomegaly. When we wish to make a diagnosis of hereditary spherocytosis, the first indicator is obviously the presence of RBCs which are having a spherical appearance with the absence of central pallor. The second thing that we need to confirm our diagnosis is we can be performing the presence of an osmotic fragility test. Osmotic fragility in such condition is going to be increased. Fact number 3 I wanted to be familiar with is hereditary spherocytosis can be diagnosed with the help of a test in which we are going to be doing flow cytometry, and when we are performing flow cytometry, the dye that is being used for performing flow cytometry is eosin 5 maleimide. So eosin 5 maleimide is going to be associated with the detection of a condition like hereditary spherocytosis. The moment we are going to be talking about the other causes, for example G6PD deficiency, you would be given a history. G6PD deficiency is an example of a condition in which the patient is going to be having a history of consumption of either some kind of a beans, say for example fava beans. Patients could be having a history wherein they have consumed certain types of drugs, say for example a drug like primaquine or antitubercular therapy drugs or sulfonamides or rasburicase, all drugs which are going to increase RBC oxidative stress. This would be typically mentioning the fact that the patient happens to be an example of a male individual, so young male individual, because this is an example of an X-linked recessive condition. or the question could be making a mention of the fact patient is going to be having the presence of infections. Now in G6PD deficiency, you are having a deficiency of the enzyme glucose 6-phosphate dehydrogenase, and therefore there is going to be higher susceptibility of the RBCs to oxidative stress, as a result of which you have the presence of both intravascular as well as extravascular hemolysis. Because of the oxidative stress, you would be having precipitation of the hemoglobin inside the RBCs, that is characteristically given the name of the Heinz body, and that is what I would like you to be appreciating over here. The second thing is, because of the presence of denaturation of the hemoglobin, it may so appear that the RBCs are going to be having the presence of a bitten appearance. So that is what is going to be given the name of bite cells. Remember the fact, it is not the actual cutting of the RBC, it is just the RBC's hemoglobin is getting denatured, and because of the denaturation, that component of the RBC, that part of the RBC is not visible to you, and therefore you are going to be appreciating it as appearance like that of a bitten cell. The moment we are going to be talking about something like Heinz body, we need to be familiar that Heinz body can be best appreciated in the presence of again a supravital staining. So it is not under the routine staining that you would be having it, it is going to be under the supravital staining. Sometimes RBCs could be having an appearance wherein it may appear to you as if they are going to be having the presence which is going to be like this, as well as they could be having a situation wherein the RBCs are going to be having the presence of a stretched membrane which is going to be given the name of blister cells. So you have the presence of bite cells, you are having the presence of blister cells, you could be having the presence of spherical RBCs. All that can be seen when we are talking about the example of a condition like G6PD deficiency. So G6PD deficiency, which is an example of a very important condition so far as your exam is concerned. The best part about this condition is that this is an example of a self-limiting condition. So primarily, during that acute phase of anemia, you just have to take care of the patient and otherwise treat the primary cause, and the patient is going to be getting a very good response. Otherwise, no specific drug therapy is required for such patients. Obviously, talking about and linking that particular knowledge of our hematology to a question asked in the exam pertaining to microbiology, patients having G6PD deficiency are going to be having a protection from development of severe Plasmodium falciparum malaria. In addition, at times it may so happen that the examiners can be giving you the other name for the bite cells. Bite cells are also going to be given the name of degmacytes. So those are the additional things that I wanted you to be familiar with. Of course, as I did make a mention of the fact, Heinz body can best be seen with the help of supravital staining, say for example something like the crystal violet. Talking about the next important example of a question which is typically going to start with the history, that we have a patient who happens to be an Afro-American boy, and this boy is going to be having the presence of fatigue, pallor. He is going to be stunted with respect to his peers, and then the question would make a mention of the fact that the boy is having the presence of a non-healing ulcer on the medial side of his foot. Now that kind of a history should very well give you a hint that the boy is going to be suffering from a condition which can be something like sickle cell anemia. Alternatively, they can be giving a question, young boy, Afro-American origin, who is having the presence of repeated attacks of pulmonary infections, and then he is having the presence of heaviness in the abdomen as well, which can be because of the presence of splenomegaly, and he was found to be having the presence of pallor. So certain types of keywords in the exams can very well help you in coming to a tentative diagnosis of a condition like sickle cell anemia. Now sickle cell anemia is caused because of a point mutation. We very well know that there is going to be replacement of the amino acid glutamic acid by valine at a beta 6 position, and this is going to be contributing to the trouble in the patients. Now looking at the peripheral smear of these patients, particularly at the time of dehydration or hypoxemia, you would be having a change in the shape of the RBCs, which is going to be appearing like a sickle, and these sickle-like cells are what are going to be given the name of the drepanocytes. Now, when we are talking about the cells over here, we need to remember the fact that at times, even when you're suspecting a patient is having sickle cell anemia, they may not be having the presence of such sickling in the absence of hypoxemia and dehydration. So, we have tests which are going to be given the name of the metabisulfite test, and diethionite test, which are going to be useful for talking about a tentative diagnosis of sickle cell anemia. Patients having sickle cell anemia initially are going to be having the presence of splenomegaly because of presence of congestion, and that is associated with the presence of deposition of the fibrous tissue as well as the presence of deposition of calcium and hemosiderin, which is going to be given the name of the Gandhi-Gamna body. Over a period of time, because of the deprivation of the nutrition to the spleen gets converted into a fibrotic tissue, and that is given the term as autosplenectomy. The only good point having sickle cell disease in an individual is again it is going to be protective so far as the development of Plasmodium falciparum infection is concerned. Now, when we talk about how exactly do we tend to make a diagnosis of sickle cell anemia, of course, with the kind of history that we have, a non-healing ulcer at the level of the skin, you have recurrent attacks of pulmonary infections, patients could be having altered consciousness, there can be a male individual who can be having the presence of priapism, of course, associated with the anemia, the presence of pallor, the presence of dyspnea. We can also be talking about the presence of certain investigations which help us. So, looking at the peripheral smear, they can be showing you the sickle cells. Alternatively, we can go in for an investigation which is going to be given the name of hemoglobin electrophoresis. As I explained you in the video in detail, that hemoglobin electrophoresis in case of a patient having sickle cell trait would be giving you the presence of two bands. You can be having the presence of both HbA as well as HbS. So sickle cell trait is what is going to be denoted with the help of HbA as well as HbS. On the other hand, when we are talking about a patient having sickle cell disease, he is going to be having the presence of a single band, and the thickness of the band would tell you the amount of hemoglobin S which is going to be present in these individuals. When we are talking about the HbA, we need to remember the fact HbA is going to migrate faster towards the anode, whereas HbS is going to be the one which is going to be slower. In comparison to hemoglobin electrophoresis, a better technique any day is going to be something like HPLC. And as we discussed in the RR section of cell injury, the general video, HPLC machine can give you a quantitative as well as a qualitative idea about the kind of hemoglobin. So not only would it tell you the kind of hemoglobin that is present in case of the individual, it will also give you an idea about the amount. So as you find the graph over here, 30% HbA, 30% HbS, which is quite likely to be suggestive that the patient is suffering from sickle cell trait. Additionally, it is best if it is available that we can carry out the gene sequencing in case of any kind of a hemoglobinopathy in order to have a confirmed diagnosis. Patients obviously are going to be getting a relief when we are talking about the administration of something like the painkillers, when we do proper hydration, and we can be using drugs like hydroxyurea in them so as to reduce the severity of sickling. That is what we need to have an idea so far as sickle cell anemia is concerned. Talking about an example of a question in the exam, which will be talking about a child who's going to be having a pallor, and the child is going to be having presence of certain bony abnormalities which is going to be resulting in an abnormal facial appearance, and then the child could be having the presence of hepatosplenomegaly, which is going to be actually contributing to the development of an enlarged tummy over here. This is going to be associated with a positive family history quite a number of times, and the peripheral smear showing you the presence of microcytic hypochromic RBCs. And what you can make out over here very characteristically is presence of certain cells which are given the name of cells having a bullseye appearance or the target cells. Severe anemia with hepatosplenomegaly with features suggestive of hemolytic anemia and presence of microcytic hypochromic cells with target cells, all that goes quite in favor of the patient suffering from a condition that is given the name of thalassemia. As and when we are making a mention of thalassemia which is going to be predominating in our country happens to be the beta thalassemia, because of the simple fact it is associated with development of gene mutation. As and when we are making of thalassemia, we need to be familiar with the fact that these patients are going to be having the presence of, if it is thalassemia major, they would be requiring regular blood transfusion in order to survive. We could be having a condition in which the patient is having thalassemia intermedia, in which on and off blood transfusion history is going to be given to you. And when we are talking about the mild thalassemia, which is given the name of thalassemia trait, that is the one which is going to be having a hemoglobin of an individual in the lower range, around, I would say, more than 10 but less than 12, and the individual is going to be having no history of blood transfusion. However, the presence of microcytic hypochromic cells and the presence of target cells can also be seen in a patient suffering from iron deficiency anemia. Now, how exactly do we distinguish between these two conditions is what I told you few minutes back. You can calculate a parameter which is going to be given the name of Mendzer index, MCV divided by the RBC count. In case the value is going to be less than 13, that is very much suggestive of thalassemia. So the value is less, thalassemia is less than 13, and if the value is going to be more than 13, that would be seen in a patient suffering from iron deficiency anemia. Additionally, when we are talking about the manifestations which are commonly asked in the exam, patients having thalassemia are going to be having the development of extramedullary hematopoiesis, which can be manifested in the form of this characteristic radiological appearance, which is a hair on end appearance that you find in the X-ray skull of these patients. There is involvement of the maxilla and the mandible as well, because of the patients are going to be described to be having the presence of chipmunk facies. That's a kind of facies. So you have the presence of a depressed nose over here, you have prominent maxilla over here, and that kind of an appearance along with the radiological sign could very well give you a hint that the patient is going to be suffering from a condition like thalassemia. So child having pallor, dyspnea, the patient is going to be having stunted growth, he or she is going to be having a chimpanzee-like faces, he is having the presence of a X-ray skull appearance as hair on end appearance, and or the crew cut appearance as we call it radiologically, and there is going to be the presence of malocclusion of teeth. All that goes in favor of something like thalassemia. As I said, it's an example of a bad disorder to have in the patient, because if it is thal major, this is going to be requiring the presence of repeated blood transfusions. Now, how exactly are we going to be confirming the diagnosis for this condition? The diagnosis is going to be confirmed on the basis of the best investigation is going to be answered in the exam as globin gene sequencing. So the moment you have a doubt that your patient is going to be having a trouble with regards to the globin chain over here, the globin gene sequencing is going to be the best thing. If that is not given as an option in the exam, the next best thing to go in for over here happens to be the high performance liquid chromatographic examination of the hemoglobin, and as an alternative, as a third thing which you would find in a lot of old questions as well, we can be performing something like the hemoglobin electrophoresis, but nothing replaces gene sequencing, that is for sure. Why we also need to be familiar with this kind of a condition happens to be the fact that in case of an individual having thalassemia trait, there is always an inherent risk. There's a boy, there's a girl who is having thal trait. They could be having babies who can develop thalassemia major later. So we need to avoid that condition. And talking about the next important example of an image that they can possibly give in the exam, that is going to be a representative of the Nestrov test. As we understand, Nestrov stands for the naked eye single tube red cell osmotic fragility test. So we are going to be having a finding in case of a normal individual. The moment you're going to be taking the blood sample and putting in a hypotonic saline solution, there is going to be hemolysis, because of which the line over here is visible at the back of the test tube. So this is what is going to be seen as the control. Whereas when you are doing the same thing for the test sample or a patient having thalassemia trait, because of the reduced osmotic fragility, the hemolysis doesn't take place, so the black line is just not visible. So that kind of an image is what you need to remember so far as the Nestrov test is concerned. Additionally, we need to remember that Nestrov test is only an example of an indicator. It is only a screening test. It is not the best test or the confirmatory test. So far as thalassemia trait is concerned, the individuals are going to be having an important finding. When you are going to be performing the HPLC, you are going to be having a characteristic finding that there is going to be an elevated concentration of HbA2. So HbA2 percentage more than 3.5 gram% in a question in the exam is a good hint about thalassemia trait. On the other hand, when we are talking about a condition like thalassemia major, which is also being given the name of Mediterranean anemia or Cooley's anemia, the predominant hemoglobin that is going to be present in these individuals is going to be HbF. So big time hint in the exam that they can possibly give you with respect to differentiation between thal trait and thal major. Of course, the history of blood transfusions any day would make a diagnosis go in favor of thalassemia major. Now talking about the uncommon variant of thalassemia, which is going to be given the name of alpha thalassemia. Alpha thalassemia is going to be characterized by the presence of gene deletion. In this kind of a condition, we do have the precipitation of the hemoglobin, which is going to be HbH in the form of precipitates like this, and these precipitates are going to be therefore given the name of having the golf ball appearance. So alpha thalassemia, the uncommon variant of thalassemia, the HbH is what you need to remember over here, and the precipitates which are going to be having this golf ball appearance, that is what you need to remember so far as alpha thalassemia is concerned. Talking about an example of a disorder in which the characteristic appearance would bring a smile on your face, because this is going to be an example of a condition in which the patient typically gives you a history that he was perfectly apparently well at night, but when he got up, the first thing in the morning that he noticed was that he was having the passage of urine which was this dark colored. As and when time grew in the day, there was still passage of blood in the urine, but the intensity of the hematuria is going to decrease. So that is an example of only important example of a acquired cause of hemolytic anemia, which is still going to be having a genetic basis, and that condition is given the name of paroxysmal nocturnal hemoglobinuria. Now the fundamental problem that we have in a patient having paroxysmal nocturnal hemoglobinuria is a defect in the gene that is going to be given the name of PIGA gene. So because of the problem in this particular gene, previous exam question, GPI linked proteins are going to suffer. Now if they are asking you specifically which particular GPI linked protein is going to suffer, that is going to be answered as CD59, which is other name for MIRL, which is membrane inhibitor of reactive lysis, or we can be having a trouble at the level of CD55, which is the decay accelerating factor. So in the sequence, in the order of importance, it is a PIGA gene problem or a GPI problem, or if they are asking about CD59, CD58 and CD55 and C8 binding protein, you need to answer the commonest CD molecule being affected in the patient is CD59. Now PNH is going to be an example of a condition which is characterized by a triad. Point number 1, patients are going to be having the presence of hemolytic anemia. Fact number 2, because of the trouble at the level of the GPI linked proteins, patients are going to be having the presence of pancytopenia. So even though the name says hemoglobinuria, it is not a disorder of RBCs, it's a disorder of RBC, WBC and platelets. And third fact that you need to remember is patients are going to be having the presence of thrombosis as well. Why that thrombosis becomes important is because if there is going to be a thrombosis, particularly of the hepatic veins, that's given the name of the Budd-Chiari syndrome, and the Budd-Chiari syndrome is going to be responsible for causing death in a patient having PNH. PNH is not going to be having any kind of a presentation at the time of infancy. Additionally, we need to remember it is having a definitive association with the presence of myelodysplastic syndrome. Now, apart from the routine presentation, that is in the form of presence of hemoglobinuria manifesting as passage of altered color of urine as the first thing in the morning, patients at times could be having a presentation which can be in the form of development of aplastic anemia. But we need to remember the fact, even though PNH has a definitive association with leukemia, patients having PNH can progress to developmental leukemia. Leukemia is never the initial presentation of a patient having PNH. So patients usually are going to be having hemolytic anemia as a presentation. There could be a situation patients can be having features suggestive of pancytopenia as a presentation. Patients could be having even the features suggestive of something like the aplastic anemia, which is quite similar to pancytopenia in terms of presentation. But leukemia is never ever an initial presentation in a patient having PNH. Once a patient is suspected to be having PNH, no, this is going to be a crude way by which you can tentatively diagnose. But at the same time, in order to confirm your diagnosis, you have to carry out investigations so that you demonstrate that there is definitely an absence of CD55, CD59. So that is what is going to be performed with the help of a technique of flow cytometry. Flow cytometry. So flow cytometry will show you both the types of cells. You are having normal cells also and you are having the presence of abnormal cells also, because PNH is going to be a problem at the level of the myeloid cells. So you are going to be having both the types of cells in the same individual. This is given the name of the biphenotypic appearance on flow cytometry, and that is the characteristic appearance that you get in a patient suffering from PNH. So this is what we need to have an idea so far as the paroxysmal nocturnal hemoglobinuria is concerned. Talking about an example of a condition in which the patient is going to be having a history of being exposed to a cold temperature, and the individual is going to be having the presentation which is going to be suggestive of hemolytic anemia. Now, any kind of a history of exposure to cold temperature and the patient is having a history of hemolytic anemia, I can always help you understand, friends, that this is going to be an example of the cold subtype of autoimmune hemolytic anemia. Now, in contrast to the warm subtype, in which the nature of the antibody happens to be IgG, and the one which is going to be associated with conditions like SLE, alpha methyl dopa administration, and can be seen in a patient having chronic lymphocytic leukemia, because the antibodies bind at 37 degrees Celsius over there. Over here, what we find is that RBCs are going to be having an agglutination, and therefore this kind of a disease is going to be given the name of cold agglutinin disease. So on the low power magnification, you would have the RBCs which are forming clumps like this, and on the high power magnification, you are going to be having RBCs which are going to agglutinate. So one of the ways by which you are going to be making a tentative diagnosis of this condition is you have the history of an individual who, let us say, walks out in the winter months, and then he is going to be having the presence of acrocyanosis. Then what you find is that there could be a presence of something like the feature suggestive of hemolytic anemia. So what you do is you take the blood sample of this individual, put a drop on the chilled slide and make a smear, and that is what is going to be showing you the presence of agglutination of the RBCs like this. Now, this is an example of a condition that is typically associated with infections like mycoplasma. It can be seen in patients having malignancies, especially Waldenstrom's macroglobulinemia. We need to be familiar with the fact that the nature of the antibody in such patients happens to be typically IgM. The best thing which can be done for these patients would be rewarming, so that this agglutinated group of cells are going to separate out, and that is likely to be helpful in them. This condition is to be differentiated from another condition which is given the name of the cold precipitin disease, the one in which we are having the presence of the biphasic antibodies which we talked about earlier, which are given the name of the Donath-Landsteiner antibodies. So important fact for us to remember over here is that peripheral smear showing us agglutination of the RBCs, and this is what is going to be seen as a characteristic appearance of the peripheral smear in a patient having cold agglutinin disease. Talking about an example of a question in which the peripheral smear is going to be given to you, in which the RBCs are going to be appearing fragmented to you, and this is going to be highly suggestive of the fact that the patient is suffering from a condition which is given the name of microangiopathic hemolytic anemia. The moment we are talking about microangiopathic hemolytic anemia, the different causes can include a condition like DIC, or the patient could be having the presence of hemolytic uremic syndrome, or he could be having the presence of thrombotic thrombocytopenic purpura, or the patients could even be having the presence of a history of going in for a cardiac valve replacement surgery. Incidentally, all of them have been asked in the exam as question. Out of them, the commonest reason for development of a microangiopathic hemolytic anemia happens to be something like DIC. Additionally, we need to be familiar with the fact that whenever we are going to be talking about the replacement of a cardiac valve, this is what is going to be seen as an example of a macroangiopathic hemolytic anemia. But the question in the exam would be talking about a patient having a peripheral smear like this, and the question in the exam would then talk about the patient having a hemoglobinuria. He is going to be having the presence of elevated LDH values. He is having elevated values of serum bilirubin, a kind of a question which was given in the recent NEET PG exam as well. So the point that you need to remember over here is that mechanical damage to the RBCs caused by the artificial valves, because they are going to be having reduced plasticity, is what is going to be associated with development of such cells, and such cells are going to be given the name of schistocytes. Please be familiar with the fact that schistocytes are sometimes also being referred by the name of helmet cells. So helmet cells or schistocytes are going to be seen as a finding of a patient suffering from microangiopathic hemolytic anemia, and you need to be familiar with another important example of an uncommon cause of development of this condition, which can be something like a giant hemangioma. So giant hemangioma and cardiac valves are going to be responsible for causing development of macroangiopathic hemolytic anemia, whereas DIC, HUSTTP, they all are responsible for causing microangiopathic hemolytic anemia. Talking about an example of a question which will talk about a patient who is going to be having a presentation suggestive of aplastic anemia or associated with something like a pancytopenia. The moment you are going to be talking about, let us say, a patient having a history of pancytopenia, this is going to prompt you to do a bone marrow examination. When you try to perform a bone marrow aspiration, what you get over there is a dry tap, and therefore you go in for something like a bone marrow biopsy, and this bone marrow biopsy is going to be actually revealing you a lot of facts. Under normal circumstances, if you look at the bone marrow biopsy, you would be having 50% cellular area and 50% is going to be because of the adipose tissue. But when you are looking at a patient suffering from aplastic anemia, as you can find over here, there is hardly any cellular element here and there. The complete bone marrow appears to be infiltrated by the presence of the non-cellular element, and there is going to be therefore too much of an acellularity. So this is what is going to be suggestive of the presence of aplastic anemia. In fact, that's another important image which was given in one of the recent exams. They all appear and there is a fatty infiltration because of those whitish areas that you can observe. That is very much suggestive of the presence of aplastic anemia. Examiners have asked you the question that there could be unrelated conditions, but again in the same breath I can talk about, wherein they talk about the presence of something given the name of aplastic crisis. The moment you hear the term aplastic crisis, you would associate it with something like a parvovirus infection. Additionally, we can be talking about an example of a condition which is going to be given the name of pure red cell aplasia. Pure red cell aplasia is an example of a condition which is going to be having an association with a tumor which is given the name of thymoma. So we need to be just familiar with the fact that in a patient having aplastic anemia, there is going to be reduced cellularity to an extent that majority of the bone marrow is going to be infiltrated by the fat cells. Additionally, we did make a mention of the different mild, moderate and the severe category of aplastic anemia, which I would strongly recommend you to go through the main videos at a quick glance. Talking about an example of an image which is uncommonly given in the exams at times, in which the image would be showing you the presence of RBCs, and these RBCs, if you observe carefully, are going to be having the presence of a teardrop appearance. So the teardrop cells is what I want you to be familiar with over here. So you need to be able to identify the teardrop cells. So fact number one, this is an image which is showing you the presence of teardrop cells. Teardrop cells can be seen in patients having multiple conditions. One of the first conditions that you need to remember over here is a patient suffering from myelofibrosis. Fact number two, that this is an example of a condition which can also be seen in a patient who is going to be suffering from thalassemia. At times, teardrop cells can be seen in a patient suffering from myelodysplastic syndrome. Might as well be seen in a patient who is going to be suffering from at times severe iron deficiency anemia. Now the fact is, the commonest condition that we need to remember in association with teardrop cells is myelofibrosis, and it is proposed that the stretching of the RBCs when they are coming from that fibrotic area of the marrow is going to make their appearance as is going to be that of a teardrop, and therefore that is what you need to remember. Of course, the teardrop cells are also going to be given the other important name. They are also given the name of dacryocytes. Dacryocytes. So dacryocyte is the name given to a teardrop cells, and those are the example of conditions where we find such cells in the peripheral smear of a patient. Continuing our discussion, we are now going to be looking at an example of a slide with respect to the different subtypes of white blood cells which are going to be depicted over here. So when we talk about the white blood cells, we just need to remind ourselves that this is how a neutrophil is going to be looking like. A cell which is going to be having presence of 3 to 4 nuclear lobes. If we are having the presence of a neutrophil which is going to be having presence of 5 or more than 5 nuclear lobes, usually that is going to be a feature associated with megaloblastic anemia. When we are talking about the second important cell, that is going to be something like a lymphocyte which is going to be having the presence of a round nucleus, and the size of the nucleus of a small lymphocyte is going to resemble the size of a RBC, which is one of the references which you keep in your mind when you are talking about a small size RBC or a big size RBC. When we are talking about the monocyte, an example of a cell which is going to be the biggest white blood cell, and that is going to be having the presence of a kidney-shaped nucleus. Eosinophils and basophils are relatively less commonly observed, but at the same time, if we talk about any example of a condition in which you are going to be having an increased numbers of both eosinophil and basophils, so combination of basophilia and eosinophilia, that is highly suggestive of the fact that the patient could be suffering from a myeloid disorder, especially a leukemia like a chronic myeloid leukemia, about which we are going to be having a discussion in the next few minutes. Having said that, these are going to be the platelets, which are going to be tiny cells over here. Obviously, these are going to be example of non-nucleated cells. Now, having a discussion about the important types of anomalies which have been asked in the exam earlier. So, the first example of an anomaly that I wish you to be familiar with over here is the one in which you are going to be having the presence of giant platelets, and along with the giant platelets, what you are also going to be finding is that there is going to be presence of basophilic inclusions inside the neutrophils. So presence of basophilic inclusions in the neutrophils and the presence of giant platelets, I mean, this combination is what you need to remember. This is going to be seen as a feature of a disease that is going to be given the name of May-Hegelin anomaly. So that has been a previous exam question that you just need to be familiar. Basophilic inclusions in the neutrophil and the presence of a giant platelet, that is going to be seen as a feature of May-Hegelin anomaly. Additional findings so far as a May-Hegelin anomaly which can be possibly asked in the exam is that if you are going to be looking at the platelet count in case of these individuals, they are going to be having the presence of a thrombocytopenia. So there is a smaller number of platelets, but those platelets are going to be big in size. That is what you need to keep in mind. Now, additional example of conditions where the platelet count is going to be reduced, but the platelet size is going to be more, can be condition which is going to be given the name of Epstein syndrome, or we have a condition like Sebastian syndrome. But the only exam question has been with regards to thrombocytopenia, big platelets, and presence of basophilic inclusions, which is seen as a feature of May-Hegelin anomaly. Talking about the next important one, we need to be having an idea about an example of a smear which is going to show you presence of neutrophils, and these neutrophils are going to be having the presence of a spectacle shaped nuclear lobe. So two nuclear lobes which are visible over here quite clearly. This is going to be seen as a finding. It is going to be given the name of a Pelger-Hue anomaly. Pelger-Hue anomaly is going to be seen as an example of a problem. What they can ask you in the exam is that the reason for the development of this kind of a trouble is because of a problem at the level of the lamine B receptor. You also need to be familiar with the condition where we have the presence of a pseudo Pelger-Hue anomaly. I mean, this kind of a condition is because of a genetic defect. It's an example of a congenital problem, but pseudo Pelger-Hue anomaly is going to be seen in a patient suffering from a condition which is given the name of myelodysplastic syndrome. So the keyword over here happens to be the neutrophil having two nuclear lobes. Talking about the next important example of a condition, you would find over here the presence of neutrophils, and if you can appreciate over here, they are going to be having the presence of dark intensity staining granules. Now this is going to be an example of a condition that is seen in a patient which is going to be suffering from Elder-Riley anomaly. Elder-Riley anomaly is going to be an example of a condition that would be coexisting in a patient who is already suffering from a condition like mucopolysaccharidosis. We need to be familiar with the fact that these patients are going to be having the presence of, and the reason for that intense staining is the presence of prominent eosinophilic granules. Talking about the next example of a question which will talk about the fact that there is an individual who is suffering from some kind of a bleeding disorder, platelet dysfunction. He is having the presence of neurological manifestation. There is presence of oculocutaneous albinism, and he is also having presence of giant granules which are seen inside the neutrophils. So when you're talking about the giant granules inside the neutrophils and albinism and presence of bleeding defects with neurological manifestations, as I have already shared with you earlier friends, this is going to be seen as a feature of a condition which is given the name of Shidiak-Higashi syndrome. Recall from our discussion earlier, the fundamental problem over here in Shidiak-Higashi syndrome is the failure of fusion of the phagosome with the lysosome, and that is because of the defect in a protein that is given the name of the LYST protein. So this is going to be the characteristic picture that you need to remember, presence of giant granules inside the neutrophils. Talking about the next important example of a condition, we are going to be having a discussion about the conditions which are associated with WBC neoplastic proliferations. So in the exam, they ask you a lot of questions with regards to something like leukemias. Now we understand the fact that in case of leukemias, as per the WHO definition, we should be having a demonstration of a fixed criteria of the blasts in order to call it by the name of an acute leukemia. Now, even though in context of acute lymphoblastic leukemia, we do not have that kind of a cutoff being defined with the WHO exactly, but is being presumed over here is that for most of the situations, if the cutoff of the blasts, and the blast over here happens to be something like the lymphoblast, so if the lymphoblast is going to be more than 20%, that is highly suggestive of acute lymphoblastic leukemia. So classically, this would be a child who is going to be having a sudden onset or stormy onset of development of features associated with pancytopenia, and then he is going to be having the presence of maybe lymphadenopathy and hepatosplenomegaly as well. Now, on the peripheral blood smear, the child is going to be having the presence of lymphoblasts. Lymphoblasts are example of cells which have got three important properties. Grossly, you are going to be finding cells in which you do not find presence of any kind of granules which are visible in the cytoplasm. So we say agranular cytoplasm. We are going to be having present of 0 to 2 nucleoli which are not going to be visible quite clearly over here. Things will become better as we discuss in few minutes, as and when you look at a myeloblast. So lymphoblast is going to be having presence of non-prominent nucleoli, as well as there is going to be absence of granules in the cytoplasm. If we are going to be doing the staining, we find that the lymphoblast is going to be staining positive for PAS as well as TDT. Now, these are going to be certain hints which are going to be given and sometimes in the stem of the question which will help you crack. But please remember the fact, in order to confirm your diagnosis of acute lymphoblastic leukemia, you would be relying not only on the bone marrow examination, but the bone marrow examination is then going to be followed by the flow cytometry. So the flow cytometry would be giving a hint what is the kind of lymphoblast that is predominating in your patient. If that can be an example of a B cell, then it would be having its own markers like PAX5 and there is going to be CD19. And if we are talking about something or CD10, and if you are talking about the T subtype, it is going to be having markers like CD1, 3, 5 and 7. So the flow cytometry is going to be the most confirmatory investigation so as to make a diagnosis of acute lymphoblastic leukemia. The other thing that they ask in context of acute lymphoblastic leukemia would be with regards to the prognostic factors that we are having. So with regards to prognostic factors, you just need to have a quick look at this kind of a table for a recap. The ALL patients who are going to be having a good prognosis are going to be having the presence of an age between 2 to 10 years. Females are going to be having better prognosis. The L1 subtype would be again having better prognosis. Lesser the blast count, more is going to be the survival of the patient. The B cell subtype is going to be associated with a better prognosis. Similarly, if there is going to be presence of a mediastinal mass, that is suggestive of a T cell involvement and that would be associated with a poorer prognosis. Any kind of a hyperploidy, now that becomes a very important fact, any kind of a hyperploidy which means chromosome number if it is exceeding 50 or if we are going to be having the presence of translocation 1221 is going to be associated with a better prognosis. Similarly, if we have any kind of a trisomy, be it 4, 7 or 10, that would all be associated with a good prognosis. So I would rather recommend you to be familiar with the fact that you need to remember the features at least on one side, and obviously in the exam any other thing which is being mentioned beyond this is likely to be associated with the opposite side. So if you can remember about the female patient who is between the age of 2 to 10 years, a pre-B subtype, the L1 subtype, and you're going to be having absence of mediastinal mass and talking about trisomy 4, 7 and 10, they all are going to be associated with good prognosis. So that is what we need to have an idea so far as the acute lymphoblastic leukemia prognostic factors are concerned. Another question in the exam can be talking about the presence of an stormy onset of a patient having leukemia, and the patient would be having features suggestive of pancytopenia. But when you do the peripheral blood examination, you would be getting cells, and these cells are going to be having an appearance like this. Now, fact number 1, you are having the presence of granular cytoplasm over here. In fact, those needle-shaped structures that you get are modified azerophilic granules. So they are going to be given the name of Eor rods. So that is one important fact. The other important fact is that you are going to be having the presence of much more prominent 3 to 4 nucleoli, which can be appreciated over here with respect to something like a myeloblast. Now, myeloblast is going to be important for the simple reason that the stains which are going to be useful for detection of a myeloblast would include something like myeloperoxidase as well as Sudan black B. So read the question carefully. If he is talking about presence of agranular cytoplasm, non-prominent nucleoli, TDT and PAS positivity, it goes in favor of a lymphoblast. Whereas if he is talking about in the stem of the question, the peripheral blood showing you presence of a granular cytoplasm, or he makes a mention of Eor rods, or mentions the presence of a large number 3 to 4 nucleoli, as well as the presence of myeloperoxidase and Sudan black B positivity, this would be associated with the patient who is going to be suffering from AML. Important fact regarding AML that we need to keep in mind is some of the AML subtypes are going to be having typical presentations. Let us just have a look at the WHO classification so far as the AML is concerned. So AML currently is going to be having 4 important subtypes. First category is AML, which is going to be having the genetic aberrations, and these genetic aberrations are the ones where you have specific translocations which can be demonstrated. So we talk about AML with translocation 821. We talk about AML with inversion 16, that's translocation 1616 as well, AML with translocation 1517, and as you find, all of them are going to be having a very favorable prognosis. The only important thing that I would like you to understand over here is the AML with an example of a genetic aberration which is going to be having a poor prognosis is the one in which you have a translocation 11q and V would stand for variable. So any kind of a question in the exam which talks about translocation 821, 1517, inversion 16, or for that matter the presence of a mutated NPM1, they all would be having good prognosis. Exception is what you need to remember for an INI CET exam. If you are talking about AML with translocation 11 and variable, which means any other chromosome, and we are talking about the presence of KMT 2A fusion, this would be associated with the poor prognosis. Additionally, when we are talking about translocation 15-17, this is going to be associated with the high risk of development of DIC. You also would appreciate the fact the patients are going to be having the presence of numerous aor rods, and the patients can be treated very well with the administration of a drug like the all-trans retinoic acid. So far as translocation 821 is concerned, that is going to be at times associated with the malignant cells causing infiltration of the retroorbital tissue, and therefore the patients are going to be having a presentation in the form of proptosis. That kind of a tumor is also given the name of a chloroma. It's also sometimes being referred by the name of a granulocytic sarcoma. So you need to be familiar with that presentation. If we are talking about the second subtype, this is going to be AML with MDS-like manifestations. So either the patient could be having a history of a prior MDS, which is going to be the myelodysplastic syndrome, or he is going to be having the presence of multilineage dysplasia, or he could be having the presence of MDS-like cytogenetic aberrations. They all are going to be associated with poor prognosis. Whenever we are going to be talking about MDS like cytogenetic aberrations, we would refer to the 5q deletion, we would refer to something like 7q deletion, the 20q deletion, and the third important subtype is AML, which is going to be associated with administration of some therapy. So this is the one which is going to be having the poorest prognosis. Therapy related AML would mean that the patient is having a history of some administration of an anti-cancer drug, classically an alkylating agent or topoisomerase inhibitor or radiotherapy, which is going to be responsible for induction of secondary mutations. And as you understand, already the patient is receiving alkylating agent therapy, he is receiving radiation, and if he develops mutations now, these are going to be very, very aggressive cells, and therefore the prognosis happens to be worst. They are going to be having the worst or the poorest prognosis. AML, which is not otherwise specified, I mean, you are neither having a specific translocation, nor it is going to be therapy related, nor it is associated with MDS like manifestations. This is given the name of AML NOS, not otherwise specified, in which you are going to be having, I would say, the wastebasket kind of a category. We have AML minimally differentiated without maturation, AML with myelocytic maturation, AML with myelomonocytic maturation, with monocytic, erythroid and megakaryocytic maturation. Now, out of all that list, important for us to keep in mind would be that if we are going to be talking about the AML, which is going to be associated with the presence of gum hypertrophy, that would be referred to the AML which is going to be having the presence of something like the myelomonocytic and the monocytic differentiation. That's one important thing to be remembered. So gum hypertrophy as well as involvement of the skin, sometimes referred by the name of leukemia cutis. If we are talking about AML with erythroid maturation, this is going to be associated with the fact that the erythroid subtype is going to be defined by more than 50% dysplastic maturing erythroid precursors. Now, why this becomes important is because this particular variant, and I repeat that AML with erythroid maturation can be having a situation that this can also be example of a AML which is going to be having the presence of PAS positivity. Now, you would have a doubt in your mind that PAS positivity is also seen as a feature of acute lymphoblastic leukemia. The difference is what I am going to be explaining you in the subsequent slide. In case of ALL, you would be having the lymphoblast which is going to be having a patchy PAS positivity, sometimes referred by the name of dot positivity, dot like positivity. Whereas in case of AML, which is the AML with erythroid maturation, you would be having the PAS positivity which is going to be diffuse in nature. So that is the important thing you need to keep in mind. So far as AML with megakaryocytic maturation is concerned, this has got two important significances. This is the type which is going to be having a megakaryocyte maturation, so it is associated quite commonly with the development of myelofibrosis. Also, this type of an AML is important because this would be seen in a patient who is going to be suffering from trisomy 21 or Down syndrome. So that's exactly what they would love to make a mention of in the exam: myelofibrosis as well as the high chance of being associated with Down syndrome. Other way of putting up a same question is that what kind of a marker would you have over here? So because it is going to be associated with a megakaryocytic maturation, this type of an AML is going to be having the presence of antibodies against the von Willebrand factor, or for that matter against the platelet antigens like glycoprotein 2b3a. So you need to be just familiar with those 4 different types of AML from the perspective of your exam. So I believe most of you should be able to identify the lymphoblast and a myeloblast quite clearly. Lymphoblast, I repeat, agranular cytoplasm, and you do not have presence of prominent nuclei, PAS positivity, TDT positivity. When we are talking about a myeloblast, yes, you are having the presence of those needle-shaped structures or there is granules, and you would be having the presence of prominent nuclei over here. In addition, you need to remember myeloblast is going to be having MPO or Sudan black positivity, and of course we talked about the different subtypes of ALL as well as AML. Now talking about the concept which I was sharing with you, in case of a situation where you're going to be having a granular or a block positivity, a dot like positivity, this is going to be seen as a feature of a lymphoblast. Whereas when you're talking about the diffuse staining, the diffuse staining is what is going to be seen as a feature of the AML, which is going to be associated with the erythroid maturation. So that particular point is what is supposed to be kept in mind. Talking about an example of a leukemia, which is very commonly asked in the exam for the simple fact that this is an example of a leukemia that is going to be seen quite commonly in case of adults. We are referring to the commonest blood cancer that you have in case of adults, which is given the name of chronic lymphocytic leukemia. Now, there can be several reasons why the patients are going to be developing this, but the fact that we need to remember is that at a genetic level, patients are quite commonly going to be having the presence of 13q deletion. Also, this is the only important example of a leukemia which has got absolutely no relationship with history of radiation exposure. What we are finding in this kind of leukemia is a fact that because of whatever reasons, there is a genetic defect, and as a result of this, there is going to be a tumor which is going to be originating from the B cell. Now, this can be an example of a naive B cell, or this can be an example of a post-germinal center memory B cell. Why the differentiation is important for you to be keeping in mind is for the simple fact that if the CLL is going to be arising from the naive B cell, it is having a tendency to be much more aggressive and therefore a poorer prognosis. Whereas if the tumor is going to be arising from a post-germinal center memory B cell, it is relatively less aggressive. Additionally, when we are talking about the mutations over here, they are responsible for causing multiple kinds of defect. Defect number one can be in the presence of a cytoskeletal protein by the name of vimentin, and therefore the tumor cells become very fragile. That is one of the key ways by which we are going to be making a diagnosis of this kind of a tumor. The tumor cells get smashed when you make a smear, and that is what is going to be given the name of smudge cells. Smudge cells. So smudge cells or the smashed cells are what is going to be seen as a very characteristic feature in association with CLL. The second fact is that these are examples of abnormal B cells, so they are quite commonly associated with development of hypogammaglobulinemia, and therefore the patients are at high risk for development of repeated attacks of infections. So gradually progressing tumor, and then the patient would tell you or agree with the fact that yes, he was having repeated attacks of infection. So elderly male with history of repeated attacks of infections, and incidentally you find that he could be having the presence of lymphadenopathy as well. And when you work up this patient, you are surprised to find that there is a very high amount of the absolute lymphocyte count in this patient. In fact, the ALC count in these patients is going to be more than 5,000 cells per millimeter cube. Additionally, if we are going to be looking at the lymph node over here in these patients, because of the proliferation of the B cells, you would have the presence of certain localized areas which are given the name of proliferation centers. When we do the flow cytometry confirmation, in order to confirm the diagnosis, you have to perform the flow cytometry. You would find that the tumor cells in this situation are going to be CD5 and CD23 positivity. Some of the patients are going to be having features suggestive of autoimmune hemolytic anemia or autoimmune thrombocytopenia as well. So that can be an additional manifestation which can be given in the exam with regards to something like CLL. So all those are keywords that you need to remember in the exam with regards to CLL. When we talk about the prognostic factors, as I told you, if the cancer is going to be having its origin from the naive B cell, that means you do not find any kind of an evidence for the somatic hypermutation that is going to be having an aggressive course. If on the other hand it is having an origin from the post-germinal center memory B cell, or you find the presence of a chromosome 13q deletion, then that's a kind of a good news for a patient, because then the tumor is going to be relatively less aggressive. Talking about the next important example of a chronic leukemia, which the examiners love to ask you time and again, and especially in the last couple of years, there have been more than 4 questions which have been given in the exam from this. So classical history would talk about an elderly male who is having the presence of a dragging sensation in his abdomen. On the physical examination, the physician found that there was presence of a splenomegaly. Typically, these patients are going to be having usually a massive splenomegaly, which means the spleen is going to be crossing the midline at times. When we take the blood sample of these individuals, we are shocked to find that there is an increased number of basophils and eosinophils in their peripheral smear. Patients can be having the presence of elevated TLC count. Along with that, platelet count usually is going to be having a fluctuation. This can be elevated, or at times it can be reduced as well. So a combination of upper abdominal dragging sensation plus blood smear showing you presence of baso and eosinophilia, plus the fact that the patient is going to be at times having a platelet fluctuation, all that goes in favor of a patient having CML. Having said that, if you are going to be looking at the peripheral smear from the blood sample taken from these individuals, you would find that these patients are going to be having the presence of different types of the cells derived from the myeloid series. So you would be having the presence of cells which are going to be in different stages of the myeloid differentiation. You would be having metamyelocytes, you would be having myelocytes, you would be having band cells, and you can also be having the presence of neutrophils. Additionally, what we find in these individuals is the fact that as and when we have to confirm the diagnosis, we have to carry out investigations. Now, CML is an example of a tumor which is going to be seen because of a translocation which is between the chromosome 9 and chromosome 22. This is going to be responsible for the formation of what is termed as Philadelphia chromosome, and there is going to be an enhanced tyrosine kinase activity. The bone marrow examination of these individuals is going to be showing you the presence of cells which are going to be having a foamy cytoplasm, and this is going to be given the name of a pseudo-Gaucher cell. Now, why exactly are we calling it as a pseudo-Gaucher cell is because we remember from our knowledge of biochemistry, Gaucher cells may be having a similar appearance, but then the history would not match. Fact number 2, Gaucher's disease is going to be seen because of deficiency of an enzyme glucocerebrosidase. Over here, we are not talking about an enzyme deficiency. We are talking about an elderly individual who is having the clinical manifestation suggestive of a leukemia. So, this kind of a cell is going to be given the name of a pseudo-Gaucher cell. Now, in order to confirm the diagnosis, you will have to show the presence of the translocation. That means you have to show the presence of the BCR-ABL fusion gene, and that kind of a thing can be done with the help of an investigation which is going to be given the name of FISH. So, with respect to the tumors that we talked about earlier, with respect to ALL, AML, and with respect to CLL, which were diagnosed or which were confirmed to be having the tumor on the basis of the CD molecular marker pattern. This is an example of a tumor in which the CD molecules will not be useful for making a diagnosis. It is rather the fluorescent in situ hybridization for which an image was given in the exam as to what is the technique that is being shown in the image. So, normally you would be having one type of a color given to the ABL gene, a second type of color given to the BCR gene, but in these patients you would be having the ABL and the BCR gene coming together. So, the coming together is going to be giving you the presence of a yellow hue, and this is what is going to be easily picked up with the help of the color probes that you have put over here. So, that is what is going to be given the name of the fluorescent in situ hybridization. Additionally, we need to remember the fact that this usually is an example of a triphasic tumor. Patients can be having a chronic phase, they can be having an accelerated phase, and they can be having a blast phase. Significance lies in the simple fact the greater is the progression of the condition of the patient. Say for example, the patient would initially be having a chronic phase which may last for few years. He would then be progressing to something like an accelerated phase. So that is going to be lasting for few months. And then the patient is going to be having the blast phase. After the blast phase, that there is a rapid downhill course of the patient, and therefore the patients typically are going to be having a trouble. The detailed analysis of the blast also reveals us a fact that this particular tumor, which was initially thought to be having an origin from the myeloid stem cell, is now going to be shown to be having an origin from the pluripotent stem cell. So that is an important thing that we need to keep in mind. Obviously, with regards to a pharmacology link, this is an example of a tumor which responds pretty well to the targeted drug therapy of imatinib. So the concept that we need to understand over here is that CML is an example of a tumor which is going to be associated with the concept of oncogene addiction. So that is what you need to be aware of so far as CML is concerned. So that is the other way of putting up a question in the exam. So this is going to be the image that is going to be suggestive of CML. This one is going to be suggestive of CLL. Now the other way of putting up a question in the exam has been a kind of, I would say, a poetic way of talking about it. In CLL, the tumor cells are going to be looking all quite similar. So it would appear to you as if you have come to a school wherein every child is going to be wearing a similar uniform. So this is what is going to be given the name of a convent girl appearance. Convent girl appearance, a term that you associate with tumor cells in case of a patient having CLL. In context of CML, you would be having myelocytes, metamyelocytes, band cells, mature cells, and therefore you are going to be having the cells which are having different shapes and sizes, which is going to be giving you an appearance as if there is some kind of a party going on and there are a lot of people who are invited. So this is what is going to be given the name of the flowers in the garden appearance. Flowers in the garden appearance. And therefore, when you're talking about something like the convent girl appearance, that is going to be seen in case of CLL, but when they're talking about something like a college girl appearance, that is what is going to be seen in case of CML. So college girl, in college you are going to be wearing different kind of clothes, and therefore that kind of an appearance is obviously going to be associated with something like CML. Of course, personally I do know of colleges where you do have a dress code still. We are talking about engineering, we are talking about medical schools over here. But then from the perspective of an exam, the concept should be clear. In CLL, tumor cells appear very similar. In CML, they are going to be quite different from each other in terms of their appearance, in terms of their shape, in terms of their size. Talking about an example of a condition which is going to be characterized by the fact that the patients are going to be having an example of a myeloproliferative disorder. And in this kind of a myeloproliferative disorder, what is going to be seen as a very characteristic finding would be that you would be having the presence of large number of those cells which are obviously usually in a normal smear going to be far less in number. So you are having a large number of platelets, and these platelets are going to be bigger in size. So essentially we are talking about an example of a condition that is going to be given the name of essential thrombocythemia or essential thrombocytosis. Now in this kind of a condition, the two characteristic findings are you would be having elevated platelet count. So there is going to be presence of thrombocytosis or thrombocythemia as we use the term. And second fact that we need to remember over here is the size of the platelets is going to be more, so you are going to be having the presence of giant platelets. Of course, we do have example of other conditions as well in which we are going to be having giant platelets, but the presence of thrombocytosis would be kind of a hint in the exam that is going to be in association with something like a myeloproliferative disorder. The platelets over here are going to be dysfunctional platelets, so patients at times can be having bleeding manifestations or they can be having the manifestations associated with a thrombosis. That is what you need to remember so far as a myeloproliferative disorder like essential thrombocytosis is concerned. Commonest mutation that you have in such patient happens to be what is going to be given the name of a JAK2 mutation. Of course, there can be additional mutations, say for example in the calretin as well, but then that is a minimum mutation that you must be aware of so far as this condition is concerned. Talking about the next important example of a myeloproliferative disorder, which will start with the fact that there is a patient who is going to be having the presence of an extremely high hematocrit. As and when there was an investigation carried out in these patients, it was found that the serum erythropoietin level was pretty much reduced. And the question can talk about the fact that this patient, on taking a hot shower bath, was having the presence of an intense itching. Associated with that, patients could be having manifestations like a history of epigastric pain because of peptic ulcer, or they could be having the presence of features suggestive of gout. Now, all that history is going to be going in favor of a condition that is going to be given the name of polycythemia vera. Polycythemia vera is an example of a condition which is characterized by the presence of a JAK2 mutation. That's a previous exam question. And what is going to be seen in these individuals is going to be that the phenylalanine is going to be responsible for replacing the valine. So polycythemia vera, that is an easy thing for us to remember. Remember the history. Taking a hot shower bath and then there is going to be intense itching. The reason for the intense itching has been explained to be the presence of high number of basophils as well as degranulation of the mast cells because of the heat exposure, and that is going to be responsible for causing itching in these individuals. Now, what we find in the examination of these individuals is that there is going to be presence of increased number of all the three cell lines, RBC, WBC and platelets. So that is what is going to be given the name of panmyelosis. Panmyelosis. However, there may occur an example of a condition during the course of the disease. I mean, after let's say few years down the line, the patient could be having a condition where the bone marrow is gradually going to get replaced by the fibrous tissue. When the bone marrow is going to get replaced by the fibrous tissue, this is going to be given the name of spent phase of the disease. It is important for us to remember that even the platelets which are going to be present in these individuals are going to be dysfunctional. So as I described for the previous one, they can be responsible for having a hypofunctioning resulting in a bleeding disorder, or they can be responsible for too much of stickiness and they can be responsible for causing thrombosis like manifestation. So key things to be remembered over here is JAK2 mutation, the change in the amino acid, the clinical manifestation, absolute increase in the hematocrit, there is going to be a reduction in the erythropoietin levels, the presence of panmyelosis, and the fact the patients in the spent phase are going to be having the deposition of the fibrous tissue in the bone marrow. Talking about an example of a myeloproliferative disorder which is going to be characterized by the fact that the peripheral smear is going to be showing you the presence of these types of cells which are going to be having a teardrop appearance. Now we talked about that earlier. This is going to be associated with a condition that is going to be given the name of myelofibrosis. The importance of knowing about myelofibrosis lies in the fact, the name gives you a hint, there is going to be a gradual fibrosis which is going to replace the marrow, and therefore there is going to be the presence of abnormalities. Say for example, you're going to be having the presence of nucleated RBCs which would appear in the circulation. The question can then make a mention of the presence of the teardrop cells, also given the name of dicryocytes. And what we are going to be having in these individuals is, if you are trying to do something like a bone marrow aspiration, that is going to be not useful because there is going to be a dry tap. However, as and when we are going to be performing a bone marrow biopsy, the bone marrow biopsy is going to be showing us presence of deposition of a lot of collagen as well as reticulin. And as you would be able to recall from our discussion in the cell injury RR, reticulin fibers and the presence of fibrous tissue demonstration can be done with the help of a stain that is going to be given the name of the Gomori stain. So reticulin fibers can be demonstrated with the help of Gomori stain, and with the Gomori stain, you're going to be having the blackish appearance which is going to be seen for the reticulin fibers. So essentially an example of a condition where there is going to be replacement of the cell element of the bone marrow with the fibrous tissue, thereby resulting in the manifestation suggestive of pancytopenia as well as the presence of abnormal cells, which are example of something like the dicryocytes. Now, one important feature which can be given as a hint to in the exam question can be that even this condition can be associated with development of massive splenomegaly. So one condition that we talked about in which massive splenomegaly can be a manifestation can be something like CML. This is the second important example of a condition I specifically would recommend you to be familiar with. Combination of teardrop cells plus combination of erythroleukemia or nucleated RBCs in the circulation as well as presence of bone marrow fibrosis along with massive splenomegaly goes big time in favor of the condition like primary myelofibrosis. Talking about an example of a condition which the examiners would be talking about in which all the 3 cell lines are likely to be affected, and because of the presence of genetic defects, say for example 5q deletion or for that matter monosomy 7 or a combination of multiple genetic defects which is given the name of complex karyotype, we are going to be having abnormality in the RBCs, WBCs as well as platelets. Now the abnormality that is present inside the WBCs, that the WBCs are going to be having the presence of 2 nuclear lobes over here. So this is what is going to be given the name of a pseudo Pelger-Hue anomaly. Pseudo Pelger-Hue anomaly. The question will then talk about the fact that there is presence of ringed sideroblasts and nucleated RBCs, as well as they can be showing you the presence of platelets which are going to be having the presence of the separated nuclear lobes like this. So this is what is going to be given the name of a pawn ball megakaryocyte. Pawn ball megakaryocyte. So I wanted to remember about the fact that in the RBCs, the abnormality can be a nucleated RBC, which is going to be present in the peripheral blood. There can be presence of ringed sideroblasts in the bone marrow as well as in the blood. You could be having the presence of the megakaryocytes, which are having the presence of separated nuclear lobes. This is given the name of pawn ball megakaryocytes. And the WBCs will be showing you the presence of a pseudo Pelger-Hue anomaly. The condition I am referring to over here is going to be given the name of myelodysplastic syndrome. Now, myelodysplastic syndrome earlier in the children used to be caused because of monosomy 7, and in the adults it used to be caused because of something like chromosome 5q deletion. But now you need to remember, so far as our country is concerned, the commonest reason for the development of myelodysplastic syndrome is given the name of complex karyotype. What we mean by the term complex karyotype is that the patients are not going to be having one genetic defect which is going to be observed. So there is a combination of multiple genetic defects because of which the patients are going to be having a development of this kind of a condition. Myelodysplastic syndrome also acquires significance because these patients can gradually have a progression, and they can be progressing into development of conditions like a leukemia, acute myeloid leukemia, or myelodysplastic syndrome has got a definitive association with a condition that we talked about in the RBC disorders as well, something which is given the name of paroxysmal nocturnal hemoglobinuria. Talking about an example of a question which will be asking in the exam, which will be describing an example of a individual who is going to be having the presence of a cervical lymphadenopathy, which is typically going to be painless, and this is going to be having a rubbery texture. So rubbery painless cervical lymphadenopathy is very much suggestive of the development of a condition like Hodgkin's lymphoma. We understand that in context of Hodgkin's lymphoma, there is going to be a contiguous involvement of the lymph nodes, and the diagnosis of the patients is assisted with the help of presence of certain manifestations which are given the name of B symptoms, wherein the patients can be having the presence of fever, Pell-Epstein fever, even though present in a very few subset of patients, but then there is going to be a regular pattern of fever which can be seen for few days, after few days again no fever, then few days there is a fever, again after few days no fever. So that kind of a pattern is what is given the name of a Pell-Epstein fever. Patients could be having the presence of weight loss as well as night sweats. So that combination of manifestation, weight loss, night sweats, presence of Pell-Epstein fever, presence of a cervical rubbery lymphadenopathy which is painless, all goes in favor of a patient suffering from Hodgkin's lymphoma. One of the characteristic findings of Hodgkin lymphoma is that the lymph node biopsy examination of these tissues, these patients, is going to be revealing you the presence of cells which are going to be having the presence of 2 nuclear lobes, and there is going to be presence of prominent nuclei therein. Such an example of a cell is what is going to be given the name of a classical Reed-Sternberg cell, something which your examiners love to go after time and again. The classical Reed-Sternberg cell is going to be having a property that this is going to be having a positivity for markers like CD15 and CD30. CD15 and CD30. Of course, when we are talking about Hodgkin lymphoma, we need to recall that there are going to be a classical variant and there is going to be a non-classical variant of the Hodgkin's lymphoma. The classical variant of Hodgkin lymphoma would be having the presence of Reed-Sternberg cells which are having the expression of CD15 and CD30. The non-classical variant of Hodgkin lymphoma are going to be having Reed-Sternberg cells also, but those Reed-Sternberg cells in the non-classical variant are going to be absent. They are going to be negative for CD15 and CD30. Now, having a look at the important example of a subtype of Hodgkin lymphoma, which is characterized by the deposition of the fibrous bands, thereby responsible for the formation of a nodule-like structure. This is what is going to be given the name of nodular sclerosis Hodgkin's lymphoma. Nodular sclerosis Hodgkin lymphoma happens to be the commonest subtype of Hodgkin lymphoma that we are going to be having in the world. But so far as India is concerned, in India the commonest subtype happens to be mixed cellularity. This nodular sclerosis Hodgkin lymphoma is also going to be having a very good prognosis. In fact, amongst the classical Hodgkin lymphoma variants, this one is going to be having the best prognosis. In case of nodular sclerosis Hodgkin lymphoma, there is a secretion of TGF-beta which is responsible for the fibrotic bands. And the reason for the secretion of TGF-beta is the presence of this kind of a cell which is going to be given the name of, this kind of a Reed-Sternberg cell is given the name of a lacunar cell. The reason why you are calling it as a lacunar cell is because of the fact that there is a retraction of the cytoplasm when you are going to be fixing the slide. So that's the nucleus, and the cytoplasm is going to retract, thereby giving an empty appearance of the nucleus. So it appears to you as if the nucleus is sitting in an empty area, and for that very reason it is going to be given the name of a lacunar cell. What you also need to remember over here is that there can be other subtypes of Hodgkin's lymphoma. Say for example, the non-classical Hodgkin lymphoma, in which we are going to be having presence of lot of lymphocytes. So those black dots that you see, the slide is almost filled with them, and you would be having the presence of a cell having an irregular contour. So the cell which is going to be having an irregular contour would be reminding you of a popcorn kernel. This cell is given the name of a lymphohistiocytic Reed-Sternberg cell, also referred by the name of a popcorn cell. The non-classical variant of the Hodgkin lymphoma is important for the fact that in this individual, you do not have the evidence of the infection caused by Epstein-Barr virus. That's fact number one. Fact number two, this one is going to be having an excellent prognosis. So out of all the 5 variants, nodular sclerosis, mixed cellularity, lymphocyte predominant, lymphocyte depleted and lymphocyte rich, this lymphocyte predominant one, which is a non-classical variant, is having the overall best prognosis, excellent prognosis. The Reed-Sternberg cells over here are given the name of the lymphohistiocytic Reed-Sternberg cell, also called by the name of popcorn cell. These cells are not going to be having expression of CD15 and CD30. So the next question which comes to our mind is they would be having an expression of CD20. That is an important thing that we need to remember so far as this particular variant is concerned. Of course, if I have to talk about the variant of Hodgkin lymphoma that is quite commonly seen in our country, that happens to be mixed cellularity Hodgkin lymphoma. This kind of a Hodgkin lymphoma is going to be associated with the presence of maximum amount of B symptoms of fever, night sweats and weight loss. And the importance of knowing about the mixed cellularity Hodgkin lymphoma is that in the background, you are going to be having the presence of the mononuclear cells. You can also be having the presence of eosinophils over there. So far as the lymphocyte depleted variant is concerned, it is seen in case of immunosuppressed conditions, especially in an individual who has a history of suffering from something like HIV. Lymphocyte rich variant, as we talked about earlier in the main video section, is classically seen in case of elderly individuals. So fundamentally, you need to remember the 2 subtypes of Hodgkin's, the classical variant and the non-classical variant. Overall, it is a non-classical variant which is going to be having an excellent prognosis, and the slide for which is what is present in front of you. So this is what we need to have an idea so far as Hodgkin lymphoma is concerned. Talking about an example of the non-Hodgkin lymphoma now, when we are talking about the non-Hodgkin lymphoma, one of the fastest growing examples of non-Hodgkin lymphoma is what is appearing on your screen. So this is going to be having a classical history that in an endemic area, particularly a child coming from Africa who is going to be having the presence of a jaw mass, and because of the presence of a jaw mass, you find over here a presence of an aggressive kind of a growth. Now, this is an example of a tumor right from the history. African child with a jaw mass having such a finding is going to be very much suggestive. But at the same time, examiners can be kind enough to give you a histological image as well of the lymph node biopsy. The tumor I am talking about over here happens to be given the name of Burkitt's lymphoma. Now, so far as Burkitt's lymphoma is concerned, they have asked you questions in the exam pertaining to the genes which are involved in Burkitt's lymphoma. So, Burkitt's lymphoma is usually going to be associated with overactivity of the c-MYC gene. There is a very critical role that is going to be played by chromosome number 8 over here, on which you are having the expression of the c-MYC gene. So translocations which are associated with Burkitt's lymphoma have been asked in the exam, and we need to remember and revise translocation 814. Apart from that, we need to be familiar with translocation 822, and we need to be familiar with translocation 28. All in all, as a concept, I wanted to remember it is translocation 8 which is going to be critical, because this is what is going to drive the rapid proliferation of the tumor cells over here. Now, this kind of a tumor is going to be very strongly associated with the infection caused by Epstein-Barr virus. If we look at the lymph node biopsy finding of these patients, what we are going to be having is the presence of cells which are going to be the tumor cells. They are going to be having the presence of hyperchromatic nuclei. So they are forming the background over here. You find those whitish areas over here. So tumor cells are going to be removed, especially the dead cells or the apoptotic cells are going to be removed by the presence of macrophages over here. So in a dark background, I mean, that's exactly what you find over here. You have a dark background of the tumor cells, and you have empty looking areas which are going to be representative of something like stars in the sky. So this kind of an appearance is given the name of starry sky appearance. The point, however, that is to be kept in mind is starry sky appearance on the lymph node biopsy is quite suggestive of Burkitt's lymphoma. However, when we were talking about starry sky appearance with respect to the renal biopsy, that is a feature associated with post-streptococcal glomerulonephritis on immunofluorescence microscopy. Starry sky appearance that we are going to be getting so far as the brain scan is concerned is associated with neurocystic sarcosis, starry sky appearance on the echo is going to be suggestive of cardiac amyloidosis. So watch out for the question asked in the exam. Please do not jump on the answer when you look at the term starry sky appearance. I repeat that fact that the background is the tumor cell, and those areas that you find, they are going to be example of the macrophages which have come for the purpose of eating up the tumor cells. So this kind of an appearance is what is going to be given the name of a starry sky appearance. So those are the points that we need to be familiar with respect to Burkitt's lymphoma. Of course, as and when we are talking about this rapidly growing tumor, whenever you're going to be administering drugs to these individuals, there is going to be a rapid mass destruction of the tumor cells. Now, this is also an example of a condition which is quite commonly associated with the development of tumor lysis syndrome, an example of a condition which is typically observed when anti-cancer drugs or treatment is being offered to patients who are suffering from aggressive or rapidly growing tumors. Talking about the next important example of a non-Hodgkin lymphoma, the next important example of a non-Hodgkin lymphoma is going to be an example of an indolent or a slow-growing tumor affecting the lymph nodes, and this is typically going to be characterized by the presence of well-formed follicles. The moment you are talking about an indolent tumor which is going to be associated with the presence of well-formed follicles, what is going to be coming to your mind is going to be a tumor that is going to be given the name of follicular lymphoma. With respect to follicular lymphoma, we need to remember why is it going to be a slow-growing tumor? Because this is associated with an overexpression of an important anti-apoptotic gene given the name of BCL2. The more is going to be the expression of BCL2, this is going to inhibit apoptosis, and therefore the tumor cells are not going to grow aggressively. Therefore, we are going to be having a slow growth in terms of the tumor. Additionally, we need to remember the fact that this is an example of a tumor which is going to be associated with the translocation, and the translocation we need to remember over here is translocation 1418. It may so happen at a histological level that this kind of a tumor is going to be characterized by the presence of cells which are going to be given the name of centroblasts and centrocytes, which have yet been asked in the exam. Sometimes patients who are going to be having follicular lymphoma are going to be having a gradual transformation into a more aggressive tumor which is given the name of the diffuse large B-cell lymphoma. Diffuse large B-cell lymphoma incidentally is also the most common subtype of non-Hodgkin lymphoma that is observed clinically. Second fact, when there is a patient having a pre-existing follicular lymphoma and the patient transforms into a diffuse large B-cell lymphoma, this kind of a transformation is going to be given the name of Richter's transformation. This transformation is what is going to be given the name of Richter's transformation. So that's an important thing that you need to remember, that follicular lymphoma has an overexpression of BCL2. We need to remember its association with 1418, and we need to remember the transformation into DLBCL, which is the commonest subtype of NHL, is given the name of Richter's transformation. Talking about the next important image, which is going to be example of a clinical history based question, which will talk about an example of, let us say, a 50-year-old male who is coming to your clinic because he is going to be having the presence of massive splenomegaly, and he is going to be having an increased risk of development of infections. Now, the patient was found to be having the presence of a peripheral blood smear which showed you presence of abnormal B lymphocytes. So it is an example of a B cell tumor I am talking about, characterized by massive splenomegaly and the presence of increased risk of infections. Also, on the splenic examination, it was found that this kind of a tumor was unique because it caused involvement of the red pulp. So normally when we are talking about the lymphomas, they are typically going to cause involvement of white pulp with two important exceptions, and that is what can be questioned in the exam. The two important exceptions of lymphomas which cause involvement of the splenic red pulp include the condition that we are discussing over here, which is given the name of hairy cell leukemia, and the second important example of an exception that you need to be familiar with over here is the hepatosplenic lymphoma. So hepatosplenic lymphoma, hairy cell leukemia, they are examples of tumors which are going to cause involvement of the red pulp of the spleen. On the peripheral blood examination, you would be having the presence of pancytopenia in these individuals because tumor cells infiltrate the bone marrow, and therefore they are going to inhibit the proliferation of the normal cells. Phase contrast microscopy, I repeat that, phase contrast microscopy is going to be showing you the presence of hair-like projections which are appearing on the surface of tumor cells. But then, as we understand that the simple presence of the hair-like projections cannot be a diagnostic finding, so we would go in for markers. The markers by which we are going to be making a diagnosis of this kind of a tumor include CD11C. We are going to be having the expression of CD25. But the best marker that you need to be familiar with over here happens to be annexin A1. Annexin A1. Remember the fact annexin V or annexin 5 is what we associate with apoptosis. Annexin A1 is going to be the marker over here. Of course, we can be having the other markers like CD103 as well. If you are going to be looking at the bone marrow examination, the bone marrow is going to be showing you the presence of tumor cells, and these tumor cells are going to be responsible for having a typical finding that you would be finding the presence of a nucleus over here, but then there is an empty area around the nucleus. So perinuclear halo is what is going to be seen over here, and that is going to be given an appearance. It is going to be given the name of fried egg appearance. fried appearance of the tumor cells in the bone marrow is what is going to be seen. Sometimes in the questions in the exam, they would be making a mention of another important appearance that is given the name of a honeycomb appearance. So typical words that you need to remember. So hairy cell leukemia, an example of a B cell tumor. Males are commonly affected 50 to 55 years of age. Feature suggestive of pancytopenia as well as presence of something like massive splenomegaly. Examination would reveal you presence of bone marrow, which is having the presence of the fried egg appearance or the presence of the honeycomb appearance. Presence of markers like annexin A1 and the other markers that we made a mention of, and a characteristic finding, patients would be having the tumor causing involvement of the red pulp of the spleen. So all that goes in favor of the diagnosis of a patient suffering from hairy cell leukemia. Additional questions which have been asked in the exam earlier, the one-liners that you need to remember from over here is that tumor cells are going to be having a positivity for what is going to be given the name of tartrate resistant acid phosphatase. So TRAP positive tumor cells. What they've also asked in the exam is going to be the fact that because of the infiltration caused by the bone marrow, even though this may be clear to you, the bone marrow aspiration doesn't reveal you anything. So bone marrow aspiration again gives you a dry tap. So how would you confirm your diagnosis? All these appearances that I made a mention of is going to be seen on the bone marrow biopsy. That is what it would take to crack almost all the questions associated with hairy cell leukemia. Talking about the next important example of a tumor which is going to be associated with presence of a gene which is going to be given the name of the ALK gene, and this kind of an ALK gene is present on chromosome 2p. Now this kind of a tumor which is actually an example of a T cell tumor. So ALK gene, 2p and T cell tumor, all important hints for your exam, which is characterized by the nucleus is what is going to be very peculiar in this kind of a tumor. The tumor cells are having the nucleus which is going to be having the name as either a horseshoe pattern, or it can be given the name of an embryoid nucleus. Remember that word, horseshoe pattern or embryoid nucleus. These are the tumor cells which are going to be given the name of hallmark cells. Hallmark cells. So tumor cells which are going to be given the name of hallmark cells because they are having the presence of a horseshoe shaped nucleus, or they are going to be having the presence of an embryoid nucleus. These are given the name of hallmark cells, and the kind of tumor that we need to have an idea. We are talking about the anaplastic large cell lymphoma. Anaplastic large cell lymphoma. So anaplastic large cell lymphoma is an example of a T cell tumor which is going to be having these characteristics that I just now made a mention of. Talking about the next important example of a tumor which is unique in the sense because this particular tumor can cause involvement of blood as well as it can cause involvement of skin. So this is an example of a tumor which is going to be arising from the CD4 T cells, and when it is going to be causing involvement of the blood, that is a blood picture that you get. This is an example of a condition in which the tumor cells are going to be having the presence of a convoluted appearance so far as their nucleus is concerned. So that is what is going to be given the term of cerebriform nucleus. Additionally, when we are having the presence of tumor cells going to cause involvement of the skin, this is going to be responsible for causing development of what is being given the name of. You see the tumor cell infiltration over there. So that is what is going to be given the name of a Potrier's microabscess. Potrier's microabscess. The moment you are going to be hearing the term Potrier's microabscess, this CD4 T cell tumor should be coming to your mind, and what we are talking about over here is an example of a condition which is given the name of mycosis fungoides. So first example of a T cell tumor that I made a mention of over with you is just few minutes back, anaplastic large cell lymphoma. The second one that I'm making a mention of is mycosis fungoides. Mycosis fungoides has been asked in the exam by its other name as well. It is given the name of Albert-Bazin disease. Albert-Bazin disease. When the tumor cells are going to be causing involvement of the skin, this is given the name of mycosis fungoides. When similar tumor cells are going to be appearing in the blood, then that is what is going to be given the name of Sézary syndrome. And the point regarding Sézary syndrome is that it is going to be having the presence of a nucleus which is having a convoluted appearance. So that is about the mycosis fungoides, Albert-Bazin disease, Sézary syndrome that you need to have an idea. Talking now about an example of a cell which is going to be asked in the exam for the simple fact that its appearance is what is going to be very, very important. We are talking about a plasma cell. Plasma cell is an example of a cell which is going to be having an eccentric nucleus because of the presence of endoplasmic reticulum, and it is going to be having a peculiar appearance of the nucleus which is going to be having this kind of a spoke-like pattern because of the radiations coming from the center. This is what is going to be given the name of a cartwheel nucleus. Now why that plasma cell is going to become important is for the simple fact that plasma cells, when they are going to be present in the blood, they can be responsible for giving rise to a term which we discussed in the main videos in detail, plasma cell leukemia, or we can be given a question in the exam pertaining to an example of an involvement of the bone marrow, a condition that is going to be given the name of multiple myeloma. So multiple myeloma classically would be an example of a question in which there is going to be an elderly male individual who is going to be having the presence of a backache, or he could be having the presence of other manifestations, say for example features suggestive of development of anemia, or he could be having the development of bleeding manifestations because of the presence of abnormal plasma cells. Now these abnormal plasma cells are responsible for the formation of abnormal antibodies, as well as these plasma cells are responsible for causing suppression of the proliferation of the normal cells, and there is going to be secretion of multiple factors, out of which there is going to be characteristically factors which are responsible for causing the increase in the activity of the osteoclasts. In the bone marrow examination, as we can find over here, for the sake of comparison, you are having the presence of a bone marrow which is apparently normal on the right side. But in comparison, a patient having multiple myeloma is going to be having a bone marrow which is going to be infiltrated, which is going to be having too many of those plasma cells. And how do you make out the presence of plasma cells is something very clear. If you look at the cell over here, there is a presence of a cell which is going to be having the presence of an eccentric nucleus. Similarly, a cell over here, a presence of a cell which is going to be having eccentric nucleus. So too many plasma cells are going to be appearing over here in the bone marrow. Apart from that, patients could be having the presence of a high value of ESR, and that could also be associated with the presence of a rouleau formation. So again, an important hint that sometimes is going to be given in the stem of the question. So presence of lytic lesions associated with pathological fractures, presence of features suggestive of infections, features suggestive of anemia, presence of bleeding tendency in the patient, and the patients can be having manifestations like presence of lytic lesions in different bones, and the patients could be having presence of rouleau formation, or the bone marrow examination would be revealing you the presence of the excessive number of plasma cells. Of course, patients could be having the manifestations which can be seen because of impairment of the tissues, as we talked about earlier, something that is going to be given the name of the Crab criteria. So there is going to be elevated value of calcium, hypercalcemia. There is going to be presence of renal dysfunction. There would be features of anemia. There is going to be presence of bony lesions. We also need to be familiar with the fact that at times we are going to be talking about something which is going to be given the name of the slim criteria. So yes, patients are going to be having the presence of the proliferation or the predominance of one particular subtype of the light chain which is going to be present. There is going to be presence of radiological findings that we make a mention of in the MRI, and we are going to be talking about the fact that these patients are going to be having the additional manifestations which can be seen because of the intracellular inclusions as well, which forms an important area for the questions in the exam. So when we are talking about the Crab criteria, we did make a mention of the slim criteria. I talked about the involvement of the uninvolved versus the involved light chain ratio. I hope you do remember that. And when we are talking about the presence of inclusions over here, immunoglobulin inclusions are going to be giving rise to a pinkish appearance. This kind of pinkish appearance given the name of flame cells. They ask you question on the Russell bodies, which is going to be because of the cytoplasmic deposition of the immunoglobulins over here. When we are talking about the grape-like appearance, that is going to be given the name of a Mott cell. And when we are talking about the intranuclear inclusions, that is going to be given the name of a Dutcher body. So those different names are what should be available on your tips so far as exam is concerned. Of course, with the radiological signs that the patients could be having the presence of multiple lytic lesions in the skull, so punched out lesions in the skull, especially in case of an elderly individual, or they can be talking about the presence of lytic lesions which can be present in the long bones like the femur, or they can be talking about the presence of the lytic lesions in the pelvis. All that is quite suggestive of the fact that the patient is suffering from multiple myeloma. Now the fact is, with respect to multiple myeloma, the diagnostic criteria, the Crab criteria, the slim criteria should be on your tips, and you should be able to differentiate between the monoclonal gammopathy that we have with multiple myeloma vis-a-vis the other condition that we did make a mention of in the main video, which was Waldenstrom's macroglobulinemia. So my request to you would be that please do go back and have a look at those criteria as well as the differentiating features between multiple myeloma and Waldenstrom's macroglobulinemia so as to crack a question in the exam very comfortably. Talking about the next important example of a condition which is apparently clear to a lot of you, we are talking about an example of a condition that is going to be given the name of Langerhans cell histiocytosis. Now, Langerhans cell histiocytosis would be an example of a condition in which there is going to be characteristically excessive proliferation of the Langerhans, and that is usually because of a mutation in a gene called as BRAF. When we are talking about excessive proliferation of the Langerhans cells, these are example of kidney-shaped cells which are going to proliferate against a background of lot of eosinophils, and there is going to be presence of cells which are having a grooved nucleus. The essential feature in association with this kind of a disease lies in the fact that the Langerhans cells are going to be having the presence of special type of granules, and these granules are going to be having an appearance which is described so many times and is given to you as a question in the exam. This is going to be given the name of a tennis racket appearance. Tennis racket appearance. Now, even though morphologically those appearances are important from the perspective of getting a hint to crack a question, however, in order to identify a Langerhans cell, it is always better that we are familiar with certain types of markers. And as in when we are talking about the markers, we have markers which are going to be HLA-DR. We have a marker that is given the name of S100, and we have a marker that is given the name of CD1A. Also, we need to be familiar with the fact from the name Langerhans cell itself, you understand the fact that there is going to be an expression of a protein that is going to be given the name of langerine over here. So we need to be familiar with this kind of fact so far as the tennis racket appearance of these Burbeck granules is concerned. So those granules are going to be given the name of Burbeck granules. Of course, you need to be familiar with the markers over here as well. So far as Langerhans cell histiocytosis is concerned, we are familiar with the different subtypes of Langerhans cell histiocytosis. One is going to be something like eosinophilic granuloma. We talk about something like the presence of a Hand-Schüller-Christian triad. We talk about an example of a pulmonary subtype of Langerhans cell histiocytosis as well, which is in fact given the name of pulmonary LCH, and that is an example of a condition which is associated with smoking. Now, why that pulmonary LCH becomes important is if an individual is going to quit smoking, then this particular condition is going to be having a remission. Talking about the recap of the important conditions associated with platelet disorders, though I would strictly recommend you that the total duration of the platelet videos is going to be pretty less. So you need to kind of watch them. And especially when we want to talk about the differentiating feature between the bleeding disorders caused because of a clotting factor trouble vis-a-vis the platelet dysfunction, we understand the fact that the bleeding disorders caused because of a clotting factor problem is characterized by the bleeding because of a presence of a tissue involvement, say for example the joints and muscles. So we have got development of hematoma and hemarthrosis. Typically, this is going to be associated with a history of trauma. Whereas when we are talking about the platelet trouble, there is an example of a spontaneous bleeding, and that too a very minor kind of a bleeding, cutaneous bleeding in the form of development of PTK as well as purpura. So that is going to be irresponsible for causing evaluation of these individuals so far as the subtype of the different disorders is concerned. Talking about an example of an important disorder which has been asked in an exam earlier, we are going to be making a reference to an example of a condition that is going to be given the name of Bernard-Soulier syndrome. Now recall from our discussion in the main video, Bernard-Soulier syndrome is going to be seen because of the presence of a glycoprotein defect, and this kind of a glycoprotein defect is going to be seen affecting glycoprotein 1b. So glycoprotein 1b9 defect is going to be responsible for causing development of this condition. Now this would be an example of a functional platelet disorder, meaning thereby that sometimes patients can be having a normal platelet count, but in spite of that patients are going to be having the manifestations in the form of PTK and purpura. A peripheral smear finding of a patient having Bernard-Soulier syndrome is going to be revealing you a very interesting fact, friends. The patients are going to be having presence of big sized platelets. So platelet size over here is going to be increased. Giant platelets are going to be seen over here. Remember the other important disorder where I did talk about the example of a giant platelets typically seen in case of a peripheral smear. That was an example of a condition which was given the name of the primary thrombocytosis, essential thrombocytosis or primary thrombocytosis. That was also having the presence of giant platelets. But over here, we are talking about a functional platelet disorder, glycoprotein 1b defect, and then it is going to be having the presence of giant platelets. A totally opposite disorder that I would like you to aware of be over here is an example of a condition which we also talked about in the discussion of immunodeficiency disorders, which is going to be given the name of Wiskott-Aldrich syndrome. Now recall from our discussion that in contrast to Bernard-Soulier syndrome, which is an example of an autosomal recessive condition, Wiskott-Aldrich syndrome is an example of an X-linked recessive condition. This is an example of a condition which is going to be seen because of a trouble at the level of a protein given the name of VASP protein, that is a Wiskott-Aldrich syndrome protein. Patients in this condition are going to be having the presence of small sized platelets. In addition, the patients are also going to be having the presence of thrombocytopenia. There is a classical triad that we get in case of Wiskott-Aldrich syndrome characterized by thrombocytopenia. Patients would be having eczema and they are going to be having elevated levels of IgE antibody. They would also be having the presence of a skin rash which is attributed to the presence of thrombocytopenia. So the key word is that in case of Bernard-Soulier syndrome, autosomal recessive disorder, glycoprotein 1b defect and big platelets, and when we are talking about Wiskott-Aldrich syndrome, there is eczema, there is skin rash, there is thrombocytopenia, recurrent attacks of infections, and the patients are going to be having presence of thrombocytopenia along with small sized platelets. Talking about the next important example of a condition which is going to be seen, and that is an example of a repeat image which I presume all of you can recall now. This is going to be showing you the presence of cells which are going to be fragmented cells, and these kind of cells are going to be given the name of schistocytes. The moment we are talking about schistocytes, what is going to be coming to our mind would be an example of a condition where there is a physical damage to the cells, and that would be an example of a condition like angiopathic hemolytic anemia. So what I am making a mention of over here would be a condition associated with microangiopathic hemolytic anemia. Now, the moment we are going to be talking about microangiopathic hemolytic anemia, I want you to remember that there are going to be different causes like DIC, TTP and HUS. Interesting for us to be familiar with over here is that in case of these conditions, especially the commonest one happens to be something like DIC. So they can be talking about the history in case of DIC, multiple histories can be given, but majority of the patients who are going to be suffering from DIC, there is going to be presence of some kind of an obstetric history. So presence of a retained placenta, presence of a dead fetus, presence of amniotic fluid embolism, and then the patient is going to be having the development of thrombohemorrhagic manifestations in them. Additionally, there can be certain types of malignancies or cancers which can precipitate DIC. For example, a blood cancer like AML-M3, for example, carcinoma of the pancreas, for example, carcinoma of the stomach as well, which can be contributing to development of this condition. Now, in context of DIC, what we need to remember over here is that these patients are going to be having elevated values of bleeding time. There is going to be increase in the value of PT, there is increased value of APTT, and there is going to be presence of thrombocytopenia. Additionally, because of the activation of the fibrinolytic pathway, patients suffering from DIC are also going to be having a higher concentration of development of D-dimers. So fibrin degradation products as well as D-dimers are also going to be elevated in these patients. Those are the important terms that we need to remember so far as the presence of cystocytes and the associated findings with respect to DIC is concerned. Now, talking about the summary of some of the important examples or disorders that they typically give you in the exams, we can be talking about an example of a disorder which is given the name of hemophilia A. Hemophilia A is going to be characterized by an example of an X-linked recessive disorder which is seen because of deficiency of factor 8. Now, because of deficiency of factor 8, what you find is that there would be a normal platelet count and there is going to be a normal bleeding time, because you need to remember the fact that bleeding time is going to be an indicator of platelet function. So, because of the involvement of factor 8, there is going to be a problem at the level of the intrinsic pathway, and as a result of which what we find is the abnormality that is going to be seen in these patients is going to be they are going to be having elevated values of APTT. However, the PT values in these patients are expected to be perfectly normal. As and when we are making a mention of hemophilia B is going to mimic hemophilia A, but the difference would be that in this condition, there is going to be a deficiency of factor 9. So for that reason, hemophilia B is also going to be given the name of Christmas disease. And again, there is going to be a similar finding. There is going to be an increase in APTT. We can differentiate the increase in APTT, which can be seen because of hemophilias, and the one which is seen because of the development of factor inhibitors by carrying out what I discussed with you in detail in the main video, the mixing studies. The moment we are talking about a condition like von Willebrand disease is seen because of a problem at the level of the von Willebrand factor, a factor that is being produced by the endothelial cells and the megakaryocytes. So I hope you remember about the Weber-Palade body in the endothelial cells and the megakaryocytes. The von Willebrand factor is going to be responsible for having a function. It helps in the attachment of the platelets at the level of the endothelial cells. So it is responsible for the process of platelet adhesion, as well as recall the fact that it is responsible for causing the other important function of transporting factor 8. Any kind of a problem at the level of von Willebrand factor. Now this can be an example of a type 1 von Willebrand disease, or an example of a type 2 variant, or we have an example of the type 3 variant. The type 3 variant is going to be the most severe subtype of von Willebrand factor, wherein we are going to be having the maximal deficiency. The type 1 variant is the one which is going to be the commonest one, and that is going to be an example of an autosomal dominant condition. And whenever we are talking about the type 2 variant, this is the one in which we are going to be having the presence of a functional von Willebrand factor defect. Remember, type 1 and type 3 are quantity problems. In type 1, there is a mild decrease. In type 3, there is a very severe decrease, but type 2 is going to be an example of a functional problem at the level of von Willebrand factor. Eventually, what we find in these patients is the platelets are not able to adhere properly to the endothelial cells. So, the platelet count as such is going to remain normal, but because the platelets are going to become dysfunctional, we are going to be having an increase in the value of bleeding time. Because von Willebrand factor is going to be important for increasing the half-life of factor 8. So it is understood that there is going to be an alteration in the functioning of the intrinsic pathway, whereas the extrinsic pathway is going to remain perfectly normal. So that would explain the kind of changes or the direction of the arrows that I have marked over here, and that has been a standard question which has been asked in the exam. So far as an example of a condition like liver failure is concerned, that is going to be causing multiple troubles. Liver failure is going to be associated with a decrease in the production of a hormone like thrombopoietin. Therefore, you are going to be having a reduction in the platelet count, as a result of which there is going to be an increase in the bleeding time. Liver failure is also going to be associated with the failure of the synthesis of the clotting factors. Therefore, PT values and APTT values are going to be increased. But point to be remembered is that the fibrin degradation products are going to be absent in a liver failure patient. However, for the sake of a clinical concept, the initial manifestation of development of an impending liver failure is going to be a patient having the first increase in the value of prothrombin time. In contrast, if I talk about a patient suffering from DIC, the condition which I discussed with you a few minutes back, we are going to be having a decrease in the platelet count, there is an increase in bleeding time, increase in prothrombin time, increase in APTT. So everything similar to liver failure, but the differentiating feature would be, in case of DIC, patients have an excessive activation of the fibrinolytic pathway. as a result of which there is going to be the presence of fibrin degradation products. If we are talking about this and comparing this with patients who are going to be having dermatological manifestation because of vasculitis, if they are going to be having a trouble, vascular purpura, then we are going to be having no alteration so far as the platelet count is concerned, therefore no change in the bleeding time, no alteration in the clotting factors, and therefore all these parameters are going to remain perfectly normal. So that is a kind of a summary of the table of the different types of bleeding disorders which can help us crack most of the questions in the exam.